for his first meeting by our new Chief Executive, Steve Moore. So thank you so much, Steve, for saying yes. And we're looking forward to hearing from you shortly. And also, just before we get started, just like to make a couple of other introductions. And so huge welcome to Chris Balch, who's joining us, who's going to be the incoming chair of Torbay and South Devon Foundation Trust. You're very welcome. Thank you for coming. And also Anthony Martin, who is the Regional Head of Transformation for Oversight and Regulation at NHS England. And also welcome to John Trevins, who's our incoming Deputy Chief Nursing Officer, who's just joining us to observe today. And also very warm welcome to Jan Goffey from Oakhampton Hamlets Parish Council. And I look forward to responding to your question in writing, because as I think we mentioned, when we have questions that are not related specifically to the agenda, we'll respond in writing. But thank you very much. You're very welcome. So I've had some apologies. Hisham is not going to be joining us today, Hisham Khalil, and we have a number of board members who are joining remotely. Frank O'Kelly, Nigel Aitchison, Graham Clark, Donna Manson, Ruth Harrell and Kate Shields. And I know there are a couple of colleagues who have already notified in advance that they have diary clashes that mean that unavoidably they'll have to leave a bit early. So could I ask our Company Secretary, Philippa Harding, to confirm that we're quorate?
Yes, we are, Chair.
Thank you very much. And also, I'd just like to just go through any declarations of interest. Does anybody have anything that they would like to add? Thank you very much, Liz Davenport.
Thank you, Chair. Just want to note item 10 on the agenda in relation to the Torbay Section 75 agreement. And as I'm here as a partner rep, but I've got an interest in that item as the Chief Exec of Torbay.
Thank you very much. Any other updates to our declarations of interest? No, thank you. So we're going to come next to the minutes of the meeting that was held on the 7th of February, and this is an item for approval. Can I ask colleagues if there's anything they would like to add or amend on the minutes? No? So we'll take that as approved. Thank you very much. Now, what we're going to do is we would usually at this point have a citizen story, but because our citizen story links so closely to the item that we're going to be taking on primary care, we felt it was appropriate to try and bring those together so that we can have a unified rather than a disjointed conversation about that. So I'm going to come to back to that one shortly. I'm not intending to say a great deal from my chair's report, other than to comment that although it's spring outside, it still feels like there are extraordinary system pressures. And I just wanted to thank all colleagues across the system frontline and colleagues here at NHS Devon for the extraordinary work that they're putting in to try and turn this around for our communities and individuals. So without anything further, I'm going to hand over to Steve Moore. Thank you very much, Steve.
Thank you, Chair. We got to that quicker than I expected. Well, look, firstly, I'm not going to go through the report in detail, but I just wanted to start by genuinely thanking everyone around the table and out in the organisations in Devon for the really warm welcome that I've received. I'm still getting around to see system leaders and others, and I apologise to those I haven't yet been able to see, but I think I've met many people now, and of course that's been really helpful as part of my induction to get a sense of where we are and the challenges we have, as already mentioned by the Chair. I think I probably just wanted to pull out two key observations, which are covered either in my report or elsewhere on the agenda, but things which have struck me since I arrived. And of course, board members won't be surprised that the first of those is the significant organisational change process that we are currently going through. The exec team have been going through, as board members will know, a really careful process which has fundamentally been focused on how we can limit the impact on our substantive workforce. However, we all recognise that despite that, there will be some impact on our workforce. And of course, at a time when we are facing so many pressures, when the timescales around this are now so tight, it is something which has really struck me, both in the number of staff meetings that I've done, but also many one-to-ones I've had with staff across the organisation. So we clearly, for me, there's a few key things that we are working on in ensuring that we get right. The first is that we published a revised timeline to get to the point where staff have some certainty about what the structure looks like. And we've, as an exec team, all looked each other in the eye, and we are going to ensure that we deliver that timeline, because I think one of the key messages back from staff has been the sense that this has been going on for some time, albeit that it's been a very complicated process for the reasons I've said. The second thing is to gather together all of the work that our HR colleagues have done around ensuring we have proper support for people as we go through this. When we get to the point where there is certainty for people, there will be a need to ensure that every individual has access to support and guidance and well-being services. So Piers and the team are putting that together for me at the moment. We should also recognise in that that the HR team itself is under huge pressure to get through all of this. There's an enormous amount of work still to do. And of course, they are also affected by this change. So we need to ensure that we are especially vigilant with that team. And then I guess coming out of the other side of this, because we will come out of the other side of this, I've started discussions around what our organisational development, leadership development and wellbeing development will be for this organisation. And I've had a few conversations with staff about the importance that we start a process of making this organisation a positive place where people want to come to work in the morning, where we develop skills and we reach out into the system and become genuine system partners. So there's going to be a lot to do, both to get through this current phase, but also then to start the building of a really strong culture across the organisation. So for me, that kind of very much was front and centre for my first couple of weeks from all quarters, really, including from board members who I know share a lot of those concerns that I've mentioned. The second has been the enormous amount of work that's gone into pulling together the operational plan, that part of our annual plan, which will address the key issues set out in our NOF4 status. It's been frenetic. I think it's fair to say there have been a number of regional and national meetings. The work that the organisation's done, I think, has been commendable, but also the sense of joint working across the communities, across our providers in Devon has been markedly different, I've been told, from previous years. I think that has meant we are in a stronger position now than we have previously been. Of course, I'm new to this, so this is my first experience of it. I would say as well, there's still an awful lot to do in relation to that plan. So tying down the ways in which we're going to mitigate the risks, this plan is not without its risks, as well as ensuring that we've got good granular delivery plans that sit underneath all of that. That work is currently ongoing and is taking up a lot of time. But I think it is ambitious, but it's deliverable. And in the end, we've got to ensure that as an organisation and as a system, what we set out balances those two things so that we can deliver what we say we're going to do. So it's been I won't say a trial by fire, but certainly an interesting time to join an organisation that's going through all of that all at the same time. But I would kind of leave my final observation that what we have in the ICB and across the ICS is a set of remarkable individuals, a real commitment to make a difference. And I'm hoping that we can build on that going forward.
Thank you so much, Steve. Does anyone have any questions for Steve? No? Excuse me. At this point, we're going to come on to the next item on our agenda, which is the National Oversight Framework Segment 4 and our progress towards NOF4 exit. And thank you very much, Bill Shields, our Chief Finance Officer, is going to lead on this item. Thank you, Bill.
Thank you, Chair. It'll actually be a double act between me and Anthony Fitzgerald, the Chief Delivery Officer. I'll actually talk about this in a bit more detail than usual because we've got a number of new board members here today. So just to remind everyone, the system finds itself in the National Oversight Framework Segment 4. That is the highest level of scrutiny that any system can be subjected to. In the report, you will see the various NOF, or SOF as it was previously known, domains in terms of quality of care, access and outcomes, people, preventing ill health and reducing inequalities, leadership and capability, finance and use of resources, and local strategic priorities. And then also the fact that every organisation within Devon, with the exception of Devon Partnership Trust, finds itself in NOF4. And there are various reasons why the organisations find themselves in NOF4, but on the next page, the progress against exit will show you where we are in terms of those criteria. If we're on track, we'd be green, and then there's a range of colours that go between green, amber, red, blue, and then grey. As board members will know, we find ourselves in the unfortunate situation where on most of those domains we are either amber or red. And taking those in turn, in terms of leadership, the assessment at this point in time is amber, and each of these assessments has been discussed and agreed with NHS England in the recent SIAG meeting that we had. Some of those ratings have been moved, but each of these now represents the agreed position between ourselves and the regulator. On strategy, we've moved to a green position, and that relates to the work that's been done to bring together the Peninsula Acute Sustainability Programme and the various other aspects of strategy that the system is dealing with. And one example there would be the recent agreement to set up a single governance board to take forward the single instance of the EPIC electronic patient record within Devon at this time for all of the acute providers. Moving on to the other categories, and I know that Mr Fitzgerald will cover these in a bit more detail. On our position with unscheduled and emergency care, we remain at a red rating rather, and although we've seen some improvement in recent days in terms of our position, we still are in a position that is not where we want to be. The requirement for us this year is to exit this year with a 4-hour wait standard of 76% and move on to 77% next year. We're seeing that level of performance achieved in some providers on some days, but not in a sustained way at this time. And there are a range of programmes and investments that we're currently looking at to determine how we can reprioritise the way in which we do this going into the next financial year. And it's something that's featured very much in the discussions that we've had with NHS England in the sign-off of our operating plan. On elective recovery, we remain red, but we have seen some significant improvement in our elective performance during this year, in some providers more than in others, but I think there's reason to feel much more confident as we move into 24-25 in terms of our elective performance. I think it's fair to say if it had not been for industrial action, we would have achieved these targets and we would in fact have been ahead of where we expected to be. So with that one caveat, our expectation as we move into 24-25 is to continue to see sustained improvement in elective recovery. When we consider the financial position, this is something that's featured very much in the discussions that we've had with NHS England, both in terms of the outturn for 23-24, and you'll see that's covered in the finance report, but also in the plan for 24-25. Our expectation this year is that we will continue to achieve the position that's been forecast at H2. There's no reason to see any deterioration in that position, and that will be that we'll deliver £49 million deficit position after receipt of additional funds from NHS England. As we move into next year, we have forecast a deficit position of £68.4 million, and that, although it is a slight deterioration, actually demonstrates a number of improvements. One is the delivery of significant cost improvement across the system. So the forecast position for this year continues to be one of £212 million being delivered across all of the providers, which is the highest level of CIP that's ever been delivered in NHS Devon. Also an improvement as we go from 23-4 to 24-5 in our underlying deficit and in the exit run rate. But, and this is a major caveat, significant levels of cost improvement having to be delivered across providers, particularly acute providers in 24-25, so levels in excess of 5 and 6% in some of those providers, and in some cases not all of that cost improvement at this point in time identified. I think those are the high level points that I want to make in terms of where we are. I'm sure that Anthony will add some detail, particularly as it relates to the performance aspects, but I will obviously take any questions, particularly relating to finance.
Thank you. I just wanted to add a little bit more detail in terms of particularly the UEC elements around our emergency care trajectories and where we sit. And obviously we don't sit where we would want to, and considering we had a comprehensive plan to improve performance, some elements of that have not landed, although we have seen continued and sustained improvement in no criteria to reside and also length of stay across most of our providers. That being said, we haven't seen the improvement in our 4-hour performance, nor our ambulance waiting times in a sustainable way. I appreciate winter pressures are winter pressures, but actually we would have expected to be in a better place. That being said, we launched in early January a series of actions which went into February and March to improve the position. One of them was related to delivery of 76%, and following national edicts, we came up with a comprehensive plan with our providers to return to the 4-hour standard. We have seen some traction and some sustained delivery in at least 2 of our providers in terms of a return to that standard, and actually have even achieved 76% on at least one occasion over the last week. That being said, that's very green and very early shoots of improvement. What we want to do now is turn that into something far more sustainable. So the pieces of work that we've commenced, firstly looking at alternatives to ED attendance and also to primary care attendance, not forgetting that most of our activity and our attendances happen outside of a hospital. We've been working with GIRFT to look at what out-of-hospital services are in existence across all 3 of our localities. And we've had those draft reports back last week. We're going through those with a fine-tooth comb to see what the opportunities are for either recommissioning, decommissioning, or actually changing our service models going forward. We're very fortunate to have Dr. Anthony Helmsley leading a piece of work to focus on new models of care and actually what our emergency care model should look like going forward. And I think, like lots of systems, there is a tendency to layer individual elements, individual schemes, and not to think about the complete patient journey. And part of what Dr. Helmsley is doing is focusing on what that pathway looks like from almost inception right through to discharge. And he's got a number of clinicians working with him on that, and I'm sure would be more than willing to come and speak to the board about some of that work, which is very much in its early stages, but we've had very good clinical buy-in so far. We've also taken the time to look at what our overall delivery of out-of-hospital services looks like, both in terms of the alternatives to ED report, but also about how we've commissioned those services previously, what the finances look like, where we're spending, and what actually the opportunities could look like. And that work is coming together as we speak. The other elements that we're looking at are actually where we have spent in the past, and I think it has been discussed in many different forums as to some of the decisions we've made, some of the commissioning decisions in particular, as to how we could spend that money differently and what services we could offer. So all of those pieces of work are coming together in a short, medium, and long-term delivery plan for UEC, which I'd be delighted to bring back at a future board, because there are many constituent parts within that. I think one thing that we have been heartened by, though, is actually the commitment from our providers to return to a 76 or a 4-hour standard over recent weeks and months. And that has not been by spending huge amounts of additional monies. That has been actually about grip and control within individual organisations and actually looking at what each patient is waiting for in our departments. And been very pleased as to the results that we seem to be getting from that. In terms of elective care then, if I can just go on to that, obviously we have missed our trajectories, and I think we would all fully recognise that if it hadn't been for industrial action, it would be a very different story. That being said, we're living with industrial action and living with future industrial action, according to ballots last week, so we do have to plan accordingly. Our trajectories, which we have missed in certain areas, we are now revising and working with our providers as to what the opportunities are in terms of mutual aid, but also that sustainability piece, because we know that we also spend a lot of money in a large number of areas trying to reduce our waiting times, and actually we have to really focus on productivity going forward. So that is our focus in terms of elective care. Happy to take any questions about those elements of the report, and we'll be picking up some of them further in terms of the IQPR later as well.
Thank you very much, Anthony. And I think Graham Clark was wanting to come in first.
Sorry, yes, actually, that was on the finance section, Chair, so I don't know if you want to go back or not. I was just going to ask Bill about the capital plan element, which has been rated downwards, as to what that now entails for us to achieve that.
Thanks, Graham. I think the major issue that we have with capital is the availability of CDEL, of the capital within the system. We know that that's constrained in the current year, and every indication as we go into 2024-25 is that that will be the same, if not greater pressure on the system and in individual organisations. That will certainly have an impact on some of the strategic plans that we have, whether that's part of the new hospital programme or whether that's those plans that we have in terms of ensuring that fabric of the buildings that we provide services from is something that can continue to be done in a safe way. I also think that there will be some significant pressure on frontline digitisation monies, which is a source of funding that we will have to utilise for the single instance of Epic across the acute providers. So significant risk. I would expect to see the risk around capital, not only for this system, but across the NHS, be one that actually increases as we go into next year and beyond, because the ability that we and the NHS generally will have to raise funds, I think, is significantly constrained.
Okay, thank you.
Thank you very much. And Kevin Orford.
Thanks, Anthony. We've heard twice in the meeting today that industrial action is the reason that we didn't meet the elective targets in the way that we've been planning to do so. Industrial action is going to continue into the next financial year. We were talking, I don't know how we concluded this, we were talking 2 or 3 months ago about industrial action potentially having impacted us more than it impacted other health systems. And we were looking into whether or not that was the case and whether or not we could manage the industrial action differently in order to have a lesser impact on waiting times targets. So I wondered if we'd done any further work on our approach to mitigating that compared to other systems.
Yes, we have. We've actually looked at where other systems were saying that they had done things differently. We spoke to a number of different organisations as to the reality of that. We found a very different picture when we did speak to them, which was interesting. Whether we were impacted more or less than other people, I think we were impacted the same, to be perfectly honest, and that seems to be the intelligence we're getting, both from speaking to other systems, but also what we're getting from national colleagues as well. I think part of the differences, though, is because of our delivery models in Devon and actually how our elective pathways flow between individual providers. And I think that's part of the issues that we've had. I think through the One Devon pilot, we've actually smoothed some of those. So I think actually we would find some lesser impacts going forward. But in terms of the modelling, we have made assumptions in terms of the continued presence of industrial action, certainly for the first 2 quarters of next year. And we've also done a variant model for the whole of the year as well.
Okay, can I just ask one other question? Where are we on 102 weeks forecast for the end of March? So 104 weeks.
9, I believe, yes.
Right. So again, I know I keep making this point, but I think that the continuing numbers of people waiting over 104 weeks really detracts from some of the success that we're having on the waiting times target. So I know that's a comment rather than a question, but I do hope as we go into the next financial year that we can have some focus on those really, really long waiters, which your report says isn't about the patients themselves. It's not about whether or not they can be, they can have their surgery. It is about our ability to organise ourselves to do it. So I do want to see a focus on that as we go into 24-25.
Thank you. I've got Sheena would like to come in, Sheena Asana, then Judy Hargerton, then I'm going to come to Alison Williams.
Thanks. It's really nice to see the system drilling down and understanding some of the variations in productivity and challenge. I think we're making really great progress in that, so thank you very much. I've got a question about adult social care. So I can see that we're on track with regard to our efficiency savings for adult social care. I'd assume that's within Devon. But I'm also aware of recent evidence that suggests that actually councils serving older, often peripheral populations seem to be experiencing real challenges in delivering adult social care with waiting times for assessment and stuff like that. And I did notice that 2 of those councils were Cornwall and Somerset. So do we know whether and how these types of challenges in our neighbouring social care systems may be impacting upon our own ability to start to sort out some of our pressures? I'm just sort of conscious of Derriford serving, having a lot of Cornish patients, and I'm imagining to the sort of east, perhaps not, but to the east of Devon, Somerset patients. Is that an issue for us?
It's certainly an issue, and I think we've been working very closely with our colleagues in Cornwall, particularly over the winter period, and that's in two facets. One is around delays in terms of discharge, and no criteria to reside position for Cornwall patients actually in Plymouth was worse than it was actually for Devon patients. We've come up with various different working practices and solutions which we've actually developed in partnership with them. We are starting to see some reductions in those areas, but that really has been joint working between us and Cornwall. The other area though, and the area that does require further work, is around mental health delays, and particularly where they require social care input. And I think we've still got a little bit of work to do on that, but certainly the bulk of the patients aren't in that category, so this is a secondary element to us as well.
Thank you. Judy Hargaden.
Thank you very much. Two things. One, on the strikes, it's sort of a situation outside our control. It's my understanding that it's actually cost more to the NHS than perhaps reaching a deal would do. And I just wondered what assurance we can take as a board that national action, you may not know, but what do our team know about what attempts are being made to sort this out? Because it's really, whatever way we manage it, it's a very difficult local situation. I wanted also to ask, at a previous meeting, we talked about GIRFT, getting it right first time, and an expectation from the system that, not us, the system, but the broader NHS, that people will adopt it or justify why they can't. And I think at the last meeting where we discussed this, we weren't really sure that we yet had this adopt or justify. I think you weren't at the meeting, Anthony, so I'm sorry if this is coming thing, but are we now confident that our trusts are in a position to get best practice or explain why they can't? Or is there still work to do on that?
I think there's always work to do on it, but I think we've got two elements with GIRFT. One is the alternatives to ED and the reports that are coming through, which are looking at benchmarking out of hospital services across the country and looking at where we sit against those. And actually that's quite an in-depth report, which I think we do have to justify against if we're not able to deliver that level of services. It also gives us percentage scores against what that should look like nationally. So that's one element. Within our acute providers, well, they've obviously been embedded and working hard at UHP for many months. There is a very clear action plan within that, which is based on best practice. Okay. And the fortnightly meetings that Professor Tim Briggs has been sort of facilitating are very much along the lines of, this is best practice. Please justify if you cannot adhere to. So it's quite a hard line that's being taken.
And the strikes?
Well, I take the point about industrial action. That's a good question. So our understanding is that NHS England will be entering into further discussions with the BMA over junior doctors' latest decision to ballot and vote in favour of further strike action. We also need to make an assessment locally of the impact of the new legislation that government have put in place in March to limit the impact of strike action. And that's why the BMA has balloted their members to strike for both strike and for action that falls short of strike, which is things like working to rule. And we need to make that assessment too, Judy. So it's a good question.
Thank you very much. I'm going to come now to Alison Williams.
Thank you, Chair. A few things, if I may. If I could come back on Graham's question about capital and the exit criteria first. There is also an expectation, Graham, that the whole of the system needs to look at capital plans going forward, including the new hospitals programme, because the system is perfectly designed for trusts to do that work independent of one another. So each of the trusts has got a significant capital investment coming down the line for significant development of the individual hospital sites. but there is a further piece of work that needs to be done aligned to the exit criteria that looks at that across the whole of the system, side by side, so that there's an understanding of the added value and how that links with the strategic direction for services. So that's one of the reasons why the RAG rating of that particular exit criteria has changed for the want of doing that further piece of work. And that's not for the ICB to do on its own, that's going to be for the ICB to do with each of the trusts, which is critically important. If I can also come back on the leverage with Cornwall, Cornwall, as you know, are not in NOF4, but there is absolute support from the region, and I think there'll be further leverage in the 24-25 plan, where the performance, the unscheduled care performance that is being put forward by UHP as its trajectories is conditional upon Cornwall delivering a level of no criteria to reside that matches that of Devon. And that will hopefully give greater leverage with regions supporting this ICB and UHP to have some greater influence over the performance that is currently quite differential. Yesterday, the difference, it was 5.4 for Devon, 5.4% no criteria reside in UHP, was 11% for Cornwall. And that's quite a big difference. And behind those numbers, there are individual patients that are in the wrong place. So there's some further leverage there. And the other point I just want to flag is that, as you know, the current position is that the plan is for Devon to come out of NOF4 at the end of Q1 next year. That will be under review with region now, as would normally be the process. Anthony might want to say something about this. And the system will be notified of that sort of assessment fairly shortly. But one of the things that is clear, whatever the outcome of that piece of work, there's going to need to be a different gearing of both the support and the action, because the dials are not turning on the UEC performance in a way that anybody would want them to turn. That's not for the want of trying. And I think when you look at some of the sub-metrics, even in UHP, you can see that there has been some considerable movements. But the absolute measures, which are the 4-hour wait and the ambulance handovers, are stubbornly resistant, and they are just not shifting. So one of the things that will need to be absolutely considered, and I think, Anthony, you alluded to it in terms of the evaluation that needs to be completed for this year, is to really understand what has worked and what needs more of, what hasn't worked so well and needs to be stopped, and the resource, as in people and effort, as well as money, redirected. Because if that dial doesn't start to turn, then it would be very difficult to see the system coming out of NOF4. So just really to sort of reiterate that that will be clarified by region over the next few weeks. And then there may need to be a significant change in focus and support going forward.
Thank you very much, Alison, and we're under no doubt about the harm that this is causing to local people and the pressures that's putting on our frontline colleagues as well, so thank you for that. Alison, we're going to come now to Liz Davenport.
Thank you very much, and I've just got a few points on the conversation we've had so far. So the first one, in terms of learning from strike action, I do think there's been cross-organisational learning from that, and I would highlight the differential impact across organisations that Anthony highlighted to us. Day surgery pathways have been least impacted, and that's enabled us to really drive forward the delivery of activity during that period of time, and that learning is shared more generally. I also wanted to pick up a little about GIRF. So GIRF absolutely is at the heart of our operational planning and has been, and it was a real sharp focus this year. But I want to point to the work of the Further Faster programme, which is also GIRF initiated, which has been led by Tim Briggs. This has been absolutely embraced by our clinical colleagues across Devon, and we've seen some really significant improvements in overall performance, but also greater collaboration across organisations as a consequence of cardiology would be one example that I could highlight. There are others. And I think that collaboration is going to be key to addressing the long waits of 1 or 4 weeks, which I think actually are relatively small numbers and are highly specialist pathways. But I think it speaks to the importance of ongoing collaboration across the system. So the One Devon pilot, again, has been very successful, building on some of the work of the Nightingale. And that, I think, is going to be important in addressing efficiency and productivity more generally. In fact, we've got a workshop this afternoon on that, but also making sure that we're optimising total capacity to address those long waits.
Thank you very much, Liz. Graham Clark, I wasn't sure whether yours was a legacy hand or whether you were wanting to come back. So.
No, it is a new one, actually. Thank you, Sarah. Okay, so I'm heading towards the quality impact assessment work, really. So the SIP programme isn't new. We've had it in place this year, and it has achieved quite a lot, albeit perhaps slightly more non-recurring than recurring. And we've already heard that the target for the almost new financial year is very substantial indeed. We've heard that our trajectories are very demanding. So, and we've also heard from Steve, of course, that the ICB itself is restructuring. So I'm really looking for our ability to, at the very minimum, keep to the current standard and perhaps in a more challenging environment up our ability to triangulate in terms of the quality impact of that SIP programme on our delivery. I know it's quite a complex area, but I guess it's a really, really important one for us all to make sure that we can achieve multiple objectives. So the question is, are we comfortable with our current arrangements? Will they be adequate going forward, or do we need to do something more to give ourselves the assurance of that? Thank you.
I'd like to bring Penny Smith in to respond to that, and then I think, Penny, you had a separate point you wanted to make, so thank you.
So thank you, and obviously a really pertinent question. So we shouldn't forget the equality element of it as well. So equality, quality impact assessment. So we've done some baseline work and we completed a workshop, and that was well attended by our provider organisations as well as our own commissioners, Chair. Certainly, we need to be looking at the cumulative impact of the programmes, and also, so both along a pathway, but also if it's disadvantaging elements of the population. So it's a sophisticated piece of work that needs to be undertaken. The process that Bill's put in place for internal review makes it mandatory that there's an quality impact assessment before any business case is reviewed. And there's a process of making sure that we've got all of those retrospective impact assessments completed. The policy does need review, and the workshop actually identified where those improvements are needed, and that work is currently underway with a view to conclusion in about a month.
Thank you, Penny. And I think you had your hand up separately. Was it on this issue or something different? No.
Yes, there was one further issue, Sarah. So we will come to UHP and safety when we do the IQPR. But a question really to Anthony. So in the spirit of executive to executive challenge, we've talked about the GIRF report around alternatives to ED. There's something for me, Anthony, you've spoken well today about our commitment to learning from that and the baseline work that's been undertaken. We need to hold ourselves to account in the same way as we do our providers. What's the timeline for that work being completed?
So we received the draft report on Friday. We're working through it over the next 2 weeks. We have a commitment to get that report circulated, but more importantly, actually, to develop an action plan. That's the work that will be happening across April, and with a circulation and meetings with system partners at the end of April to make sure that we have the right actions in place and actually some of the decisions that are necessary within that. It is unfortunate that it didn't necessarily dovetail with our operational planning process, but we are where we are, but we'll try and do the best with what we've got. I am expecting to be able to circulate early drafts of, the finished report itself by the end of next week to executive colleagues.
Thank you for that. Bill, were you wanting to respond on this point?
Yes, please. Just the point that Penny made, I chaired Devon Investment Group last week. We looked again at all of the unscheduled and emergency care investments that were made as a consequence of winter funding that we received for this year. We reprioritised a number of those programmes, and we also deprioritised some, and we will be looking at how those investments can be made in a much more joined up way going forward. As part of that, every one of those business cases was accompanied by an EQIA. And also, we're very keen that going forward, the ICB commissions UEC work and works closely with providers to make sure that when we're looking at out-of-hospital and community services, that they're designed in a way to support the delivery of the unscheduled care targets, which has not always been the case, I think, in the system up until now.
Thank you. Now, I've got a number of colleagues that would like to come in. Nigel was next, then Frank O'Kelly, and then Tandy Hara. So, Nigel.
Many thanks, Chair. It's going back a little bit to the question that Judy asked that Liz responded to about the GIRF programme, and certainly for the elective care, the further, faster work that Liz spoke to. I think you cannot underestimate the impact of the work that the One Devon pilot has had on that collaborative working, where colleagues are genuinely sharing the desire to make sure that there's equity of access, experience and outcomes for all of the people of Devon and of East Cornwall who come to use our services. And that principle is one that's expanding out into the further, faster pilot. And we really do think, Judy, that speaks to the quality of care that we can provide for people in Devon through using those principles that have been established in GIRF. And I think the work that Liz and colleagues have done, the work that Anthony's team has done in this space, has been recognised nationally as being, really fine work. So just I think it's important to note that, Chair, that's a baseline of fantastic work from the One Devon pilot from which we can build.
Thank you very much, Nigel, and I would certainly note that. Frank O'Kelly next.
Thank you, Chair. Again, it's going back a little bit to the capital spend. I'm rather pleased that it's moved to red, and it's great news that funding is coming through to the hospitals. But I suppose the issue is in the future we're going to be doing more work out in the community. There is no identified capital spend for the community at all. And I suppose my question is, if we're a system as regards the deficit, are we also a system as regards the capital spend? Because we have seen primary care capital spend projects have to be shelved completely in the last couple of years.
Thank you. Really important point. Bill, did you want to respond on that?
Yeah, I mean, one of the issues is that a lot of the funding that we've received has effectively been hypothecated. So the NHP funding is for new hospitals, the FLD funding is for the rollout of digital for those organisations whose digital maturity is not at the appropriate level. And the amount of discretionary capital that we have across the system has been significantly constrained. Where we can, we'll ensure that we prioritise that, again, in line with the business cases that have been submitted to the Devon Investment Group. We'll be looking to both revenue and capital programmes that deliver the greatest benefit, not based on which sector they benefit. But it is definitely the case that we have, in a very, very constrained environment, and our room to manoeuvre is not that great. If there are ways in which we can recycle existing primary care state and as a consequence of that make funds available, that's something that we'll be looking at and expect that to come forward in the coming year and thereafter.
Thank you. I'm going to take two more questions and then hand to Steve to summarise. So Tandy Hara next.
Yeah, sorry, I'm just going to take us back to the point about strikes and the effect on waiting list and stuff, which is quite easy to sort of pick up. But what I want to understand is how confident are we about how much we are understanding about the effect of this on harm and quality of care? Because I think we also do need to get to a point where we can articulate the effect on not just the waiting list, which is quite easy. You know, people who were waiting 2 weeks are now waiting 4 weeks, but actually what's the impact on harm and quality?
So we've undertaken a couple of reviews already on this, and we're undertaking one at the moment, just looking at this in the context of coming to year end. So both the numbers, but more importantly, the individual patients within that. That will be feeding up through the quality board, and a report will be issued accordingly on that. I think there is also something, although we talk about industrial action in the context of elective care, it cannot be underestimated the impact it has on a workforce in terms of emergency care as well. So that is another element that we need to spend a bit more time and attention on, not just from a performance perspective, but actually the delivery elements within that. And we'll be looking to do that as well following the elective review that we're doing.
Thank you. And Kate Shields has joined us online. Kate, I'm going to bring you in and then hand to Steve. And just ought to say as well that I'm sorry, Hisham Khalil, I had received your apologies in advance, and I'm delighted that you've joined us as well. So thank you very much. Right. So Kate Shields, sorry.
Thanks, Sarah. I'm sorry I was late, but I just came in as Alison Williamson was talking about Cornwall's level of no criteria to reside in University Hospitals Plymouth. So I just thought it would be helpful to contextualise no criteria to reside across the 2 counties. So it's 20% in RCHT at the moment, Royal Cornwall Hospitals, and 11% in UHP. So whilst it's higher than we would like it to be and higher than you want it to be, there's differential access to non-acute services across the 2 counties. We've block booked 10 beds in Mount Gould, and it should be noted that 3 social care discharges were made yesterday. So there were 15 people waiting to leave UHP yesterday that were within the control of the system, 8 in the control of UHP and 3 waiting safeguarding. So I just think we need to be clear in totality, and I just wanted to add that in because it was fairly just a bold comment around Cornwall with no context.
Thank you for providing that context, Kate. That's appreciated. So I'm finally going to come to Steve Moore. Thank you, Steve.
I'm not going to try and summarise that discussion, but I think firstly just to reflect, it is really heartening that we've had such a good airing on such an important issue across the board, and thank the board for all the questions. I think to pick up the thread where Alison was, we would all acknowledge in Devon that we are not where we would want to be, that there is significantly more work to do. But as we head into the new financial year, we do, as I said earlier, have a plan which is both ambitious about what we can do, but deliverable. And I'm looking in the eyes of our providers, because much of it sits with them, although not wholly with them, about that. That's not to say there aren't risks here. And clearly this is a work in progress where we are at the moment. So we are working through identifying all the risks that we have in that plan, all the mitigations that we can put in place, as well as the granular detail about how we're going to do it. I know the board's had one opportunity to walk through informally, but that was relatively early on. We need to spend more time working through the detail of all of that with you as it's developing and emerging. And then, of course, we need to keep ourselves poised during the year, because industrial action is just one example of something which will potentially knock us off course, and we need to ensure that we are nimble enough to be able to change course across the year, because in the end, I think our acid test, our sense of success will come from the fact that we broadly deliver what it is that we've set out to deliver, not least because it's really important for the patients that we serve and the staff out in our systems who are delivering on this. Just wanted to end with just a bit of a reflection on quality, and Penny and I have spent a great deal of time since I arrived talking about quality. I think it's fair to say we've got a bit of building work to do around the ICB's ability to support and undertake a more total quality management process across the system. Clearly that will need to be really well rooted in the work that already goes on in all the provider system. But quality surveillance, quality improvement, quality management are all key things that I think we need to be able to hold the ring on going forward. So that's still very much a work in progress, and clearly links to the organisational change agenda that we've got. But I just wanted to assure the board that whilst the targets themselves are important and of course have quality implications for our patients if we can achieve them, we also have a wider responsibility to ensure that quality is front and centre of what we do. So we've got a job of work to do on that.
Thank you very much. And so what I'm asking colleagues to do now is to just note the current performance position against our NOF4 exit criteria, and to be clear that we cannot currently provide assurance that we're going to meet the target NOF4 exit date of Q1 24-25. But I think we've heard today absolute determination to move this forward, to understand the variations and where we need to do better on behalf of our community. So thank you very much to everyone who is undertaking that work. Thank you. Going to come on now to the next section, which is around our 5-year joint forward plan refresh. And I think, Jenny Turner, you're going to lead on this, and Nigel Aitchison. So is Nigel, are you going to kick off, Nigel?
Thank you very much indeed, Chair, and thanks to Jenny and Philippa in particular for their help in both compiling this, but also in helping us try and position this as we'll outline. So I take it that colleagues will have seen and read the paper, and the purpose of bringing it here this morning is to ask the board to approve the refreshed joint forward plan. NHS England requires all ICBs to refresh and publish joint forward plans each year, and as you'll remember, our first joint forward plan was published in July 2023, and the joint forward plan is really the response to the strategic objectives that were set out in the One Devon Integrated Care Strategy, which itself was set out by the One Devon Integrated Care Partnership and is a system-wide piece of work and set of programmes. Both the strategy and the joint forward plan that derives from it were informed by both public feedback and wide stakeholder engagement, and the refresh has also been informed this year by feedback from stakeholders, which includes colleagues at NHS England South West. And we've themed the refresh around 3 themes, and I think this is particularly relevant to some of the conversation we've had so far today. We're in Marmot region. Within the South West Marmot region, 2 of the most deprived, or the 2 most deprived areas are Torbay and Plymouth, and our 3 themes are healthy people, healthy safe communities, and a healthy sustainable system. The programme plans themselves haven't significantly changed, but the structure of the plan's been amended and the content has been reduced in response to feedback. And the way that you'll see this presented in the paper is we talk about some of the achievements that have been made in each programme so far, what people of Devon will see as a result of each programme, and the programme outlines objectives which are short-term, which are designed to address our recovery and the exit from NOF4, as well as some longer-term plans. It's been endorsed, I think this is important to say, by both the Devon, the Plymouth and Torbay Health and Wellbeing boards, and also it's worth noting that this is a plan for the whole system, and we in order to focus on the NHS specific elements, we plan, and this was mentioned earlier on, to have an NHS specific annual plan, which we plan to incorporate the 2024-25 operating plan, as well as the other NHS priorities alongside the NHS specific elements of the joint forward plan, and we will bring that together and present it to board in May. So that's a brief introduction. As I now hand over to Jenny for any other elements that she feels we need to draw out for colleagues, and then open up obviously to questions.
I haven't got anything else to add, Chair. Just take questions.
Thank you very much. I'm just wondering whether Councillor James McInnes wants to come in as chair of the partnership, the Integrated Care Partnership.
Thank you very much, Sarah. Obviously, as chair of the Devon Health and Wellbeing Board, we've looked at this and we're content, and I see from the comments of Plymouth and Torbay Health and Wellbeing Boards are content as well. I think for me, as chair of the Integrated Care Partnership, it's about making sure that what our 5-year forward plan and our annual forward plan is actually deliverable. And I know there has been some people who said, well, you know, your strategy is enormous, it's God knows how many pages long, but we were asked to put together a strategy that covered the wider system. But at the end of the day, in the times we're in terms of the NHS, the local government, everyone, we need to make sure that we're brave enough to actually hone things down to make sure things are deliverable. And I think that this refresh has started on that process. Thank you.
Thank you very much. I'd like to bring Graham Clark in.
Thank you. So in fact, I'm sort of building on that point, James, actually. So I guess coming from a commercial background, if I was presenting a plan that wasn't resourced, it wouldn't be regarded as a holistic plan. And I know we are limited here in what we're being asked to do in terms of its format, but I do wish to make the point that it's going to be really important going forward in linking this up to our ops plan that I know is in flight, as it were, in terms of its submission and approval in due course. But for me, I have no problem in supporting this document as it stands. However, there does need to be the question mark as to have we actually got the resources to achieve the laudable targets that are being set out in here. So I think there's a piece of work to join the dots in due course.
Thank you. What I'll do is bring in a number of points and then see if Steve would like to respond. So I know that Liz Davenport would like to come in and Sheena Asthana.
Thank you, and thank you for bringing the paper today, because it's good to see it develop and move on. I'm particularly pleased to hear that there's a plan to incorporate some of the annual deliverables in the operating plan, because I think creating that alliance and using it as a communication tool is really important. I guess I just wanted to put a bit of focus on the out-of-hospital element of this plan. We talk a lot around this board table, as we do in my board, around the importance of delivery against NOF4, which is often very hospital-orientated. And I think some of the objectives that are set here in terms of out-of-hospital are going to be critical to securing long-term success. And I'd really want to see that highlighted in the operating plan priorities for 24-25.
Thank you, Liz. Sheena Asthana.
Yes, thank you. It's also good to see progress. I think that the point's been alluded to, but I haven't fully grasped it, I think. When we're talking about our achievements seem to be we've set up a plan or we've done some training. Less in terms of what we've achieved in actually demonstrating some change for our patients or for our services, or, you know, we've got a list of indicators on page 181 of the pack, but there's no triangulation between what we're trying to say we're doing and what we're actually achieving in terms of these indicators. And I can understand this. I mean, take on board this is the second year of the plan, and we're in a we're on a journey, I suppose. But my question is are we confident that we've got the balance right with respect to our description of achievements versus challenges? Because we seem to, we're quite strong on achievements, even though they're not achievements in terms of actual achievements for people. They're kind of achievements in terms of setting up systems. And I get, well, I suppose relating really to the kind of like the balance between the description and a more critical assessment of where we're doing. So it just feels to me that this is quite different. The focus, the language is very different to what we do in the NOF4 work, where we're moving much more to honing down on the evidence and understanding the challenges, whereas this feels a bit more motherhood and apple pie. But is that because of the audience?
Thank you. I don't know whether, yes, did you want to respond on that point?
Yeah, and it's also to respond to Graham's point as well, actually. I mean, I think for me it's important to see the document for what it is, actually, which is it is a response to the integrated care strategy. It's an output from a collaborative partnership setting of ambition for the system, and so that the moment we start to put finances in it, that means you can't get to that ambition. Actually, that just gets in the way of it. So I think there's a bit of me that you perhaps wouldn't expect me to say it, but there's a bit of me that says it's quite important to take some of that out of it, and quite important to not focus too much on the detail, but keep it on the ambition. I think. I mean, it has moved on from a year ago. It has incorporated the feedback that we've had from the regional people and from around the system. And, there is this thread that runs through it of system and partnership intention, which I think, for me, we just hold on to that as we go into the next phase of planning for the year. And my big assurance at the end of it is that, we are going to link this into the annual plan work and the operating plan work by May. And I think at that point, that's the bit where, you know, we look at the level of assurance that we've got, that we've been able to do that in a way that those outputs that you're looking for, Sheena, aren't about process this time next year when we come back to it, but they are about real deliverables that we've had. So I just wanted to give that kind of slightly different perspective on the way that I've been looking at this. I mean, I think it's in a place where we can approve it for submission, but we acknowledge that there's some further work to get it into an annual plan where we can get that kind of grip that you're looking for, the kind of grip that we have on NOF4. We can do that once we've got it into an annual plan. So just wanted to give that different perspective.
Thank you, that's really helpful. I'm going to come next to Frank O'Kelly. Thank you, Frank.
Thank you, Chair. As Liz's comments, I like the focus about the community and understanding the bigger picture. I suppose the only part that I have very significant concerns about would be the Green Plan. Our objectives for an anchor organisation on page 177 seem to be wholly inadequate, and I would ask that next year it becomes an absolute focus. The reason I say that is, as an organisation that moves hundreds of thousands of people around Devon every single year, we are having a huge impact in terms of travel for the patients, and we need to think about it in terms of where we deliver our services and how we deliver our services. It might be much more efficient in terms of climate change to move one consultant to nearer to 20 patients from our patients than moving everyone to hospital sites. And I think unless we focus on it now, we have little chance of impacting on the 80% target reduction by 2028, 2032. So fine for this year, but I think it has to become an absolute priority for us as an anchor organisation in the Southwest. And I'm very interested that the Cornwall report has a small but very active group, which seems to be a voluntary sector group, that are driving things.
Thank you very much, Frank, and also for your link into us being an anchor institution. It's not just moving people, it's all the supplies as well and how we can link in better on that. I don't know whether Andrew, as the lead for Green, would like to come in here.
Yeah, I think Frank's correct. I think for me there is a lot more work though that's going on around the green agenda than probably Frank this alludes to, because I know in a lot of the providers actually a lot of the green work is done through the estates leads who do meet really frequently, so Matt and I meet with them. You refer, I think, Frank, to our objectives, but that's for our own organisation, which are quite sort of straightforward because we're a very small organisation. But the bit, I think, Frank, that probably needs a lot of work is the primary care aspects. And we have worked with Tom Waterfall as a GP, who's done some of the work around the green agenda. But the concern I have is how we resource this going forward, because this is it has great potential, the green, and we have to meet the requirements that are set out by the NHS. But for me, I think we need to look at the resourcing currently, because I think it's done in lots of pockets, but probably we could collectively do that together. And I'm looking at James, because I know, James, your county council's got announced a climate emergency some while ago, and I wonder whether part of the system approach could be how we work more collectively together between the NHS and local authorities.
Thank you very much. I'm going to bring in Judy Hargaden next, then Alison, and then James.
So I just wanted to almost disagree with you, Graham, about your comment about the fact it isn't funded being a problem. I think when you're working in the and to some extent Kevin has covered this, when we're working in the public sector, where funding always comes in annual tranches and small initiatives and other things, it's even more important to have a very clear fundamental plan for how we want to do things when we get the opportunity to do it. And of course, as Andrew's always saying, we must focus on priorities in turn. But I think, not having it clearly financed doesn't stop it being of really important value in terms of this is what we are trying to achieve as we get the opportunities to do it. It keeps us focused.
Thank you very much. Alison Williams next.
Thank you, Chair. Just really conscious that in the context of NOF4, we're living in the immediate delivery of the priorities, and the twin track with the joint forward plan is critical, so the two things are moving together. But I'm just conscious of the point that you made right at the beginning, Steve, about the capacity in the organisation, particularly with the organisational change and the reductions in headcount. There's an awful lot of work in here, and a great ambition that somehow is going to need to be matched with the capacity and capability in teams to deliver. And I'm encouraged by the alignment with the annual plan, because that will give the staff a much greater focus on the in-year actions around that. But I just wonder, is there a greater opportunity to also look at the alignment with the in-year operational plans for partners? So in the same way as the ICB is going to be reflecting the current year opportunities in its annual plan, should the ICB be requiring that or asking that, or should the partnership be requiring that of all partners? So how is this reflected in the annual plan of the local authorities and others? And is there a greater opportunity to do some of this together because of the constraints in the workforce to deliver it? And maybe that's something that could be taken offline and looked at in a bit more detail.
Thank you very much. And James, I don't know whether you want to respond to that, but I know you wanted to come in on a separate point
Yeah,
as well.
3 points really. Firstly, on climate change. You know, Devon County Council's declared a climate emergency. Torbay Council has, Plymouth City Council has. There's a lot of work going on, and we need to do this in partnership. So I agree with you, Andrew. I think, you know, we need to do it for our organisations, but we need to do it collectively as a system, because this is something that affects us all. It's not something that just affects this part of their system or that part. So I think we do need to work harder in terms of that. In terms of money, there's been obviously enough for etc. But as a layperson, my simplistic way of looking at the things at the moment is there's not enough money. We all know there's not enough money. There's not enough money in local government. There's not enough money in the... But we have to innovate to actually work with the money we've got. Because no one's going to come over the horizon and suddenly say, here's X billion pounds, everything's fine, because that's not going to happen, regardless of what government comes to power in Westminster. So that's why the importance, and that's why I'm so keen on the integrated care system, and that's why I agreed to chair the integrated care partnership, because I am a believer of partnership. And the only way out of all the things that we're suffering from is partnership. You know, we're not going to manage it on our own. So that's why I come back to Alison's point a minute ago, is she's absolutely right. NOF4, and Bill, absolutely, I get it. We want to get out of NOF4, absolutely. But in tandem, we have to have a vision of what we're doing beyond. And for me, actually, arranging services that there's actually more in the community than more focus on acute will actually keep us out of NOF4 going forward. If we don't do that, we'll end up back in it. So, you know, I'm not being depressed about it when I say that. I'm just being a realist that we have to have that tandem approach, and there really is an issue in terms of the capacity to have that, but we have to do our best to find it. Thank you.
Thank you for that really important reminder. And of course, there are issues that are not primarily in our control, like housing, but they are a key driver for people ending up in our hospitals, and how we can learn from other systems that have taken action on housing that makes people sick, or some of the other key drivers. Thank you very much. I'm going to come now to Kate Shields and then Tandy.
So just for information, I can send the details of Manda Brookman, who is a climate activist with Volunteer Cornwall, with Volunteer Cornwall. She's been working with all of our practices and helping them save money whilst also make sure that they've got the most effective sources of heating and purchasing. So if I send Manda's details to Steve, then she may well be able to provide some support around how you pull everybody together, because there's loads of stuff going on in this space. It's just that we're not always aware of it. But she is a force of nature, and she may be somebody that you would want to engage with.
Thank you so much for that, Kate. I'm going to come to Tandy and then Jenny to wrap up for us. Oh.
Thanks, Chair. So I really like this the structure of this plan, and in particular how it's linking the what we're going to do into the objectives of the ICS, giving it that golden thread. One thing that it says has changed in here is how what will change for the public, and it's really sort of nice to see how that's reflected. But I think there's a bit of conflation in there as we are describing what the public will see, going through all those themes. I think in some parts we're sort of describing enablers, in some parts we're describing outputs, which is what the public will feel in terms of reduced housing. But in some parts we're sort of describing things like a framework or sustained sustained delivery or a collaborative. Those really aren't things that the public will feel, in my view. So I think that element of what the public will see probably does need to be reviewed, so that we really articulating what difference the public will see as a result of what we're doing. And I think that really needs to be about outcomes, as opposed to some of the things we're describing in there, which to me come across as the operational difference that we want to see in there. So I think that probably needs to be reviewed along those lines.
Thank you very much, Tandy. So I'm going to come now to Anthony Martin, and then I think it would be really good, Jenny, if you could wrap up for us. Thank you.
Thank you, Chair, and I won't hold us up too long. Just a quick line on process and principle. I think it's worth stating that the JFP isn't something that NHSE assures or agrees. It's a system plan. So NHSE's role has been to kind of be supportive, kind of friend challenge on this one. So I hope that's what's been experienced. It's not something that when submitted we'll say yes or no to, but what it will do is be part of the considerations when we carry out the ICB annual assessment. So worth bearing in mind that this is part of what we look to inform that assessment, the statutory annual review. I was just thinking in that context around the look back, and that's what's particularly helpful for that process. And I think that's been done really well here, particularly as it's the first year of looking back at JFP. So I like the presentation, like the approach. I do take Sheena's point, though, around it feels a little bit like it lacks a bit of tangibility for some people who might look to read this and understand what have the achievements been, what's that meant for me and for others. But I wonder whether that might be provided through the annual report, which is also carried out by the ICB at a similar time. And once it comes to the point of publishing the JFP, the annual report would have been finalised, and there might just be an opportunity to cross-reference, because that will give a bit more detail about some of those achievements in the last year, which is really important to kind of describe a bit more to the public, I would suggest.
Thank you very much. And then finally to Jenny Turner.
Thank you, Chair. So I just was reflecting on a couple of things, actually, and it is a system-wide plan. And I think part of the issues that we face are to do as our system matures, and that we will see, as we have already seen this year, that as that maturity develops, the way of working together and the way we articulate that as a system will develop. We have tried very hard to make sure that the joint forward plan aligns with the operating plan. And given the deadlines this year, that has proved a little bit of a challenge, but we're still working on that. And actually, NHS England informed us this week that we can delay the formal publishing of our joint forward plan to make sure that it does fully reflect our operating plan. But we still need to submit to NHS England by the end of this week. I agree that it can be seen as light on detail, but that is because it was so long last time. We have removed a lot of the detail. So I'd just like to assure the board that sitting under those plans are detailed delivery plans. And what we need to do as an ICB is make sure, and as indeed an integrated care partnership, make sure that we are monitoring those more detailed deliverables that we don't articulate in here, so that we can be assured on what has been achieved and articulate that better, but also as a system you are assured that we are delivering that. And I think that will be easier when we bring that into an annual plan so you as a board fully understand what are the NHS responsibilities within that. And then just finally, this is a system plan, so it should reflect everything that we're doing, and the programme groups are system-wide groups. And so what I would hope was, as those programme groups develop these plans, they are taking them back into their own systems and informing their own annual plans. So I agree with Alison, it absolutely should be aligned, but I am also quite confident that it is. Thank you, Sarah.
Well, thank you for all the work that you and colleagues have put into this. And I think Steve would just like to make a final comment.
Yeah, thank you. So I'm still getting my head a little around all of this, the strategy, the joint forward plan and so on. So take some of this with a pinch of salt, that it may be naive, but I think the first thing to say is where Jenny left off, we absolutely need to get to the point, if nothing else because of the amount that's going on in the system at the moment, to have one single plan for next year that we're really clear about what we're doing in relation to. Clearly a large part of that will be the NOF4 stuff we've just discussed, but there will be things that we need to ensure we do within the joint forward plan as well, beyond that, because there are important issues within that. We talked a bit about resources. For me, probably the biggest worry there is not so much money, it is about people and bandwidth to be able to realistically do this. I don't know if anyone's counted, there are 136 actions here, most of which we say we're going to deliver in year 1 and 2. I think I would just like to keep the door open with the board to say we're going to need to review those when we come forward with the annual plan, to say what can we realistically do in order to address the people we've got in the system and what we're trying to do, because we do need to be convinced that we stand a reasonable chance of doing it. That's not to say all of the things in the joint forward plan don't still need to be done. We just need to think about our bandwidth to be able to do it all at once with everything else going on. And I think on that as well, I think there's the point that James made, given the constraints within which we are working and everyone is really conscious of, we do need to unleash people's creativity and perseverance to do some of this. We can't just simply do it with more money because there isn't any. So we need to think about our delivery mechanisms and how we get people optimistically to look at different ways of achieving the same thing. And then I think for Sheena's point, yeah, I think we're going to need to continue to work on that real clarity about what are inputs, what are outputs, and what are the outcomes we're trying to achieve, and start to draw much clearer lines between those things so that we can ultimately see how we're shifting the experience of the people that we serve. So I think we're going to need to be brave enough to have some of those discussions about what we can realistically do. We will bring that back in the annual plan context. And then finally, if I can just say on the green agenda stuff, yeah, completely behind that. Wales was, I think, the first country in the UK to declare a climate emergency as a country. I do think it's not something I've opened and looked into yet within Devon, but my sense is the ICB has a big opportunity, if it isn't already, to be the convener and the coordinator of a lot of work. Clearly, a lot of it will go on at provider level. Some of that is about the disposition and way in which we deliver services so that people can travel a small amount, but there's also a whole range of other things like supply chain, drugs, the sort of drugs that we use, the way that we organise our systems, and things like biophilic design. So when we're looking at our capital, as tight as it is, that we are developing facilities that help not just with climate change, but also with biodiversity and a whole range of other things. And there's a growing movement around those things, not least because the evidence is also growing that it helps to create a healing environment and a good environment for staff. So I just wanted to part that. I'm keen to get into that subject. I don't know where we are with it yet. It was something we spend a lot of time on in West Wales, and something I'd be hopeful that we can do here on top of everything else, but really important.
Well, that's really welcome. Thank you very much. So just to ask colleagues if they could approve the joint forward plan. Anyone objecting? No. Thank you very much, Philippa. So we're going to come on next to our citizen story, and I thought it would be sensible for us to move this to be just in front of the next item on our agenda, which is the Primary Care Access Recovery Plan, because it's so directly linked, the story that we're going to hear. So I'm really grateful to Arthur Govia and Jackie Meller for taking part in this presentation, and so it would be great if we could just view the video to start with. Thank you.
My name is Arthur Govia. I'm nearly 84 years of age, married with 2 children, I live with my wife in Farley Meadows, Tiverton.
My name's
In Farley Meadows, Tiverton.
My name's Jackie Meller. I've lived in Kings Girthwell for over 40 odd years.
Both my wife and I have iPads, which we use quite a lot for various things, and my wife does online banking. We have phones, a mobile phone each, which is the old type.
I obviously use a laptop for work. We've got an Apple Mac. I have a smartphone, and I have an iPad. I'm not brilliant, but I can get around it.
Well, I think pre-COVID, no problem whatsoever. It was always quite easy to contact by phone, which is what my wife is what we become accustomed to. Then, of course, COVID altered everything, and it became difficult even to contact them in any shape or form, or to get appointments. Fortunately, COVID seems to be now at least partly resolved, and there has been a distinct COVID altered everything, and it became difficult even to contact them in any shape or form, or to get appointments. Fortunately, COVID seems to be now at least partly resolved, and there has been a distinct improvement in being able to contact the surgery by phone. A distinct improvement in being able to contact the surgery by phone. As far as the contacting online is concerned, we are reluctant to do it. We're not happy and confident in doing it. And I know many older people, such as ourselves, feel the same.
I think the new system, this new clinic system, is absolutely fantastic, absolutely brilliant. You hop online, up at 8 in the morning, pop it, or just after 8 in the morning, get online, fill in the form, wait for the phone call back. I get the phone call back really quickly.
My wife has had the app for some time on her iPad. I recently put it on mine, but neither have ever used it. My understanding is that it does present problems to the older type person. Invariably, several have said to me they find it very difficult. I recently put it on mine, but neither have ever used it. My understanding is that it does present problems to the older type person. Invariably, several have said to me they find it very difficult to make an appointment online. And invariably then, even having done so, it finishes up, well, we'll offer you with a telephone appointment. All they want to know is to say, I've got something wrong with me and I'd like to see a doctor.
The app, I actually registered with the app when it was more or less first came out, and I did struggle to get onto it. Since then, my husband's registered and he's had no problem. First came out, and I did struggle to get onto it. Since then, my husband's registered and he's had no problem. We've linked it so that we can look at each other's details. I think it's brilliant because I'm, having got secondary breast cancer, I have lots of different medication. I take my tablets and I think, I'm getting low, hop onto the NHS app, order all my, having got secondary breast cancer, I have lots of different medication. I take my tablets and I think, I'm getting low, hop onto the NHS app, order all my tablets, brilliant, done, dusted, and I get a phone call from the chemist when they're ready. I've had a couple of instances where I've actually looked to see what the GP's written about me. So, yeah, it's brilliant. I can't fault it.
I think the difficulty is the older age group again. And to get... I think the difficulty is the older age group again. And to get accustomed to doing things using technology, I'm not sure that some of them is ever going to use it.
The main one is like my 93-year-old lady that I look after. She doesn't have the internet. She doesn't know how, she looks at my phone and says, oh, these newfangled things. So she wouldn't know how to fill in forms. She wouldn't know what to do technology.
There's just got to be, in my opinion, a system where people can phone, whether that means employing more receptionists or whether there is another means that there is a dedicated line open that elderly people with no facilities to deal with matters online can use. And that's the only way I can see that it's ever going to be resolved. But it is a growing number that need to be able to contact other than online.
It's just ensuring that they can go into the surgery, they can go in and actually see somebody, and it will be sorted for them, and somebody will do it for them. But it's easy to phone up and just say, I don't know what I'm doing, can you help me? And that there's a friendly voice on the other end saying, yeah, that's fine, I can help you.
But overall, I think in a region as we are fortunate to have the surgeries we've got. We're lucky to have the surgeries we got. And overall, you'd have to say that they're more than satisfactory compared with a lot of the other areas that you hear and see about.
Well, thank you very much. Apologies that there were some repeats coming into that. There was a run through before we started, so I'm not quite sure why that technical difficulty happened, but we will look into it. But I'm immensely grateful to both Arthur and Jackie for taking part. And what I'd like colleagues to do is to really hold their experiences and voices in our heads, and we will then bring that into the discussion of the next item, because they're very closely linked. Unless Frank O'Kelly may wish, our partner member for primary care, may wish to make a brief comment before we come to the next item.
I'm afraid my Wi-Fi didn't allow the film to adequately come across to me. What I would say is Arthur Govier is my patient, and he was chair of the League of Friends in Tiverton for many years, but I'm afraid I can't comment on exactly what he said today.
Thank you, Frank. So I'm going to come to the Primary Care Access Recovery Plan, and I think Nigel Aitchison is going to get us started on this, and we're also going to hear from Jill Monday. Thank you, Nigel.
Many thanks, Chair. And unfortunately, like Frank, I couldn't see the video. So in terms of the paper, again, take the paper as read. The plan was presented initially to colleagues at the board in October 23. It was well received then, and we were very grateful for the valuable feedback that we received. And what we bring in this paper is a progress update. In terms of the recommendations and actions from presenting this paper today, we'd ask colleagues on the board to note the content of the paper. We'd furthermore ask that colleagues and stakeholders consider how some of the key ambitions could be supported by system partners to help us deliver it. And I think it's also important that we're cognizant of the need to make sure that we resource this expanding and system critical primary care transformation programme properly. The GP access and resilience work, these are prerequisites to us being able to deliver the fuller integration agenda, so we absolutely need to get this right. The two key ambitions of the primary care access recovery programme are to tackle the demands, particularly the peaks of demand early in the morning, and try and reduce the number of people who find it difficult to contact their practice. And the second headline ambition is to make sure that people understand on the day that they contact the practice how their request will be managed, whether that's through a same-day appointment, the NHS app, self-directed care, or referral elsewhere. So there are 4 areas that sit underneath these 2 high-level ambitions. As I said, one of them is the empowerment of patients. The next is to modernise general practice and then build the capacity and cut bureaucracy. And so, as I say, some of those areas for empowering patients I've mentioned. In terms of modern general practice, you'll see from the paper things like cloud-based telephony, simpler online consultations, easier navigations, and helping people to get responses that they need. In terms of the capacity piece, trying to build larger multidisciplinary teams, increasing the number of doctors working in primary care, and that will include retention and potentially bringing people back from retirement, and a priority for primary care in housing developments, and it's linked to something we talked about in the joint forward plan around housing being important, but equally as we're planning those expansions in housing, we do need to make sure there's provision for primary care. And in terms of bureaucracy, improving that primary-secondary care interface. In the paper, there are some from pages 200 to 203 of our pack, it describes some of the challenges that we have. I've mentioned one of the headline challenges in terms of us being a Marmot region, and within that region, the 2 most deprived areas in the southwest being Torbay and Plymouth. But equally, there's the challenge of an ageing population, and there's a graph that you'll see showing that Devon's over 80s age group is increasing significantly now. For some of us who are closer to that than very young age, I hope that's a good thing, but nonetheless it does provide challenges for us in Devon. So I'm going to stop there. I'm going to hand over. I'm immensely grateful to our primary care team for their work, which you'll see described in the paper, and also for the colleagues that we've got across primary care in Devon. We are blessed, despite the challenges, with the colleagues that we have through the length and breadth of Devon in terms of the primary care workforce that we have. And this programme and the support that we hope to give through it, we hope will, well, as I say, lay the really solid foundation for us being able to take forward the fuller report and recommendations. So Jill, welcome and thank you for joining us. I don't know if there's anything you want to add before opening it up.
Thanks, Nigel. So I did have some things I was going to say, and obviously now having seen the video, which luckily I was able to view, I think some of it does link into that. So I think one of the things I did want to just flag was that we have made an awful lot of progress this year, and it's really important that we recognise that. And one of the things we have been working on a lot is around cloud-based telephony, which is really about making sure patients have better access on the phone to get into their practices. So all our practices in Devon now have cloud-based systems. Also the NHS app, in terms of the uptake of that, we've done a lot of work around that, and more people are using it. And as the lady in the video said, I think for some people, that is working really well. We've also done a lot of work around the additional roles reimbursement scheme in kind of boosting the multidisciplinary teams in primary care, and also some of the work we've been doing across the primary and secondary care interface as well. So I think you mentioned, Nigel, that comparatively, I think at Devon level, our general practice is very strong. We compare very well regionally and nationally in terms of appointment data. The appointments we offer per 1,000 population in Devon is nearly, I think, about 24% higher than the national average. But I think the thing that I really wanted to say was that we're not complacent around some of the variation that we see within Devon around that. So we are continuing to work with practices on an individual basis around their transformation plans. We're putting in a series of support visits as well that we'll be undertaking. So as well as kind of understanding the variation, we really need to take steps around how we address some of that. The only other thing I was going to note just briefly was that we now have got further detail about the primary care recovery plan into next year, so it will continue to feature in the operating guidance going forward. There will be a revised set of targets and trajectories. So as a team, that will be a big focus for us to continue to work through our priorities under the primary care access agenda into next year. But that's all I was going to say, and obviously happy to take any questions.
Thank you very much, Jill. I'd like to come first to Frank O'Kelly, our partner member for primary care.
Thank you, Chair. I think this paper, as I've said before, when it came to Primary Care Committee, is excellent, and I really commend the team for the effort they've gone into, the engagement with the 120 practices, and the way it's being presented. That said, I don't think we should think everything in the garden is rosary in primary care. We are in the middle of having a ballot. Primary care in Devon is struggling in many aspects, and probably 33 practices have been identified as in a state of flux, potentially, which means about a quarter of all general practice. I do have significant concerns about primary care, and primary care access, the target is 35%, we're delivering about 50% already, and the system is asking us to increase on the same day. Counterintuitively, that may in fact be the wrong thing to do, because what that does is reduce continuity of care. And we need to think very long and hard about exactly what we do try to deliver. It might be that we should be trying to drive it down to the 35%, but that the people are dealt with on the day and given some sort of appointment or alternative. Devon primary care is really, really good, but Devon primary care is also at a point where it's I think, finely balanced. In terms of the greater primary care, we have had the addition of dentistry, optometry and pharmacy, and I suppose I'd make a plea. The team have done a fantastic job delivering this document and engaging, but they are dealing with ever-increasing numbers of issues across primary care, and now with POD added to it. So yes, it all looks really, really good, but I do have some significant concerns.
Thank you very much, Frank. I'm going to bring in Judy Hargaden, Chair of our Primary Care Commissioning and Transition Committee, and then perhaps return to Nigel or Jill to respond. Thank you, Judy.
Thank you very much, and thank you. I don't know how we convey thanks to the people who did the video for us, but that was really helpful. I, like others, would like to say well done to the team. I've said it at the Primary Care Committee, but I think a lot of progress has happened through this PCARP, and I think there is now much better integration work going on between primary care and secondary care. So the document that's referred to, which now all the trusts have signed up to, has been kind of around for 18 months being shaped up, and congratulations to Alex Deegan for finally finalising and pushing it forward. But it's a really important issue that when there is pressure in the system, and boy is there pressure in the system, we need primary care and secondary care working together rather than each saying that it's the other that's causing issues. And in both these areas, there is variation, and I'm very pleased that there's a slide here on the work that's going on variation, but also this issue that Frank referred to, and I've mentioned here before, which is continuity of care. So I wanted to give one cautionary note and then one reassurance. My cautionary note, and I just wanted to say how pleased I was to see that the pharmacy integration is coming off. We've talked about making sure that pharmacy and general medical practice, work together at PCN level. And that's really important because pharmacy is under a lot of pressure too. They've got staffing issues, they've got funding issues. So if they work together, that's fabulous. The cautionary note is what gets measured gets done. And the issue about these access measures is that they are leading to perverse consequences, one of which is the peak of calls first thing in the morning to make sure you get your appointment on the day. And yet that is a goal of the improvement. So that's one issue. The other issue is this continuity of care. You may have to wait 3 days to see the same professional. If you have ongoing conditions, that's actually what you want. I have one, I want to see the same professional. And so an appointment system that highlights face-to-face appointment with GPs when actually it may be the practice nurse that's best for me. So what we really need to do is keep measuring the continuity issues as well as the access issues, even if it's only the access issues that we get national data on. My second point was to reassure you on the subject of digital access. It comes up every time we talk about digital support. We had one of the best schemes on getting patients to use online access to your GP before COVID, and our local GP, John McCormack, became a national advisor on ways to do it. And all along there has been this issue that it's no good having a system if people aren't confident to use it. So when we were talking about robotics the other day, which is an initiative out of the information team, we talked about not putting patients in a position where they can't access various services because everything's gone online now. So I would like, I don't know, we don't have the patients with us, but that message to get back to them, that it's a significant issue for us.
Thank you very much, Judy, and I think very mindful of the words that we heard from Arthur Govia. I know that Penny Smith would like to respond. Thank you.
Oh, it was on a separate issue, Chair.
On a separate issue. Can we have Jill maybe or Nigel respond on that very powerful message that we had from Arthur Govia about the need to always make sure that there is an alternative for people, that we're not trammelling people and widening inequalities potentially for those who can't manage to access online routes?
Yeah, I'm happy to pick that one up. So yes, agree, absolutely. It's a really, really important point. One of the things we have seen through some of the work our practices have been doing at PCN level on their capacity and access plans is specifically working with colleagues in the voluntary sector to host sessions in the practice around digital and IT to try and kind of support their communities. But also we're very, very clear that patients should be able to contact their practice through a variety of means, that they should be able to walk in, they should be able to phone, and they should be able to do an online consultation as well. As practices move to what's called nationally as the modern general practice access model, one of the things that we're seeing practices do now is that they're using online as their kind of digital front door almost, but patients who can't access that directly should be supported to be able to complete that by either the receptionist or someone in the practice as well. So absolutely take the point on that. It's a really important point about digital inequity, and I think it is something that practices we've seen have been increasingly cognizant of as well, and we'll continue to make sure that that's something we factor in as we work through PCOP into next year.
Thank you very much. And Sheena, I think wanted to come in next. Sheena Asthana.
Thank you very much. It's a really comprehensive and interesting paper. It's great. I've got 3 questions. The first is, I think the paper makes very clear that the change in demand, partly due to our ageing demography, but also one is aware of the fact that there is a shift in the pattern of deprivation towards the peripheries, which would suggest that we are facing really interesting increases in demand from our patients. At the same time, we've got this long-standing debate about whether the relative spend on hospitals and community services and primary care is right. Do we think it's right? Do we think we've got the balance right? Are there any plans to... I absolutely accept the NOFOR difficulties, but I think a number of us are a little bit worried about primary care and about whether or not it's being resourced in the right way, because remember, if we're doing things right within the primary care system, we should be reducing demand within the hospital system. So that's my first question. The second actually relates to digital, and it's great to see the kind of progress in the NHS app and telephony. I've got a couple of questions. The first is how I know John McCormack is absolutely brilliant, but how this is an issue for more than just one person. How do we get assurance that we are keeping up and sufficiently future ready? I'm aware of a number of things that are happening that probably are taking away even, that cloud telephony starts to look slightly old-fashioned compared to some of the things that are being explored. Are we really assured that we're doing that horizon scanning and that we are placing ourselves in a situation where we can take advantage of rapidly developing technology and actually offers that are happening? So Synos has offered to come and talk about an alternative to telephony. There's really interesting examples in Kent where we're moving away. We're actually kind of like hubs for triage, which basically you're linking all the data interoperably together, but they have the ability to do those referrals, whether it's required to A&E or to a hospital or to a community service and stuff like that. There are alternatives, and are we sufficiently aware of them? But the second question I've got is it's great to see the use of digital to support effectively admin. Are there plans to start deploying digital solutions to move us into care? So in other words, remote monitoring data, real-time data for early diagnosis, for actually management within the home, moving away from the kind of booking the appointments to the actual provision of care. Is that on our agenda?
Thank you. Jill, would you like to respond on those points?
Yes, so I think at the start of the presentation we do flag, I think, around some of the recent national research and documentation about the importance of investing in primary care if we are going to achieve kind of wider system improvement. So I think increasingly people like the King's Fund and NHS Confederation, etc., kind of supporting that view in relation to your first point. In terms of horizon scanning for digital, yes, that is very much more John's probably department than mine. But I do know through the Digital Programme Board, that is one of the things that they look at and work on. And I know, although I believe there are some capacity challenges within the digital team, that horizon scanning is something very much that John is focused on. But I'm afraid, probably not the expert in that department. In terms of the wider use of digital AI and other things, in terms of remote monitoring and things like that, I think we have taken some steps into that. But again, that's probably, in all honesty, a question for kind of the wider digital group rather than me specifically. But I'm really happy to feed those points back in through the digital board.
Thank you. Andrew, I knew that you wanted to come in, and I think as well we should probably congratulate the GP and the cloud team as well.
I was just going to say that,
you.
Sarah, because I think we often say we don't celebrate our successes enough, but actually the team, John and the team that managed the GP and the cloud, won a major HSJ award last week. A partnership award, which is a national award, so we should just highlight and congratulate them. The one thing I was going to say, Sarah, was the purpose of the video, and it's quite ironic, isn't it? We're talking about digital and it didn't quite work for some people, particularly for Frank, who I think is in much further sunnier climes, is that we undertake about 640,000 online and video consultations, and I guess the video shows that people have a mixed view about that. And I think we need to bear that in mind, because for some people it clearly works really well, but for others it's a challenge, and that was the purpose of the video, to highlight that.
Thank you very much. And then finally to Frank, because I'm conscious, Penny would like to come in as well. So
the points have been made.
Have they? Apologies, Penny, I should have brought you in sooner. So Frank Kelly and Tandy would like to come in too. Tandy Hara. Frank.
So the whole point of primary care is that you're dealing with people, and we are constantly going to need a variety of methods for people to access primary care. The vast majority of our patients are elderly. They are the ones that will need to walk in and use the phone. But if we can deal with a very significant majority by digital means, it will make it more efficient and therefore make it possible for those people. What we've got to make sure we don't do is exclude them by limiting phone and walk-in access. The only other thing I would say about primary care access is it's entirely system dependent. If you have 7.4 million people on waiting lists, they come and see their GP I don't know how many times while they're on that waiting list. So the whole system managing to become more efficient and more productive will make primary care access better.
Thank you. Really important point. Tandy Hara.
Yeah, a little bit of an extension to what you just said. I mean, clearly, if we're saying digital is the way forward for health, and at the same time we're saying we do need to allow people to access it if they need to walk in, I think what we need to do is to work out which ones of the population absolutely can't and won't be able to access in that way, and then try and support those ones. But actually everybody else must be supported towards this way, because otherwise we're going to end up with the 50-50 situation in which people choose and pick, and I think that the efficiency of that would be a little bit difficult. So I think if we can find a way of looking into our data and drilling down who actually will struggle and working with those and giving them access to that whilst everybody else goes digital, is what I would suggest.
Thank you, Tandy. So could I ask, Steve, did you want to make any final points?
I think we've had another good discussion about it. I would perhaps suggest, because I think what we see in the report, and I think Frank's referred to it, is a primary care system which is being asked to do more and more, faster and faster. I think another 500,000 appointments compared to pre-COVID being delivered last year. Clearly digital is part of that, but there's also all sorts of other things. I just wonder whether there might be an opportunity for a board seminar around primary care more generally, because I think it links to the point that Sheena made about we can probably acknowledge, and we would all know, and Devon's not alone in this, that where investment has gone for all sorts of good and maybe unavoidable reasons has been much more into the acute sector, but we know the importance of primary care in its widest sense going forward. I think we need to have a bit of time just to reflect ourselves on what the strategy might look like that starts to reverse that trend, as difficult as it will be. Whilst, of course, the organisation gets on with the annual plan and NOFOL and all those things, I think we've got a bit of time just to reflect, because it is, I'm not saying this because Frank's virtually in the room, but it is the foundation upon which everything else is built. And I think we need to look beyond just trying to make it go faster towards actually how we can make it better for everybody, including the people who work in it.
Thank you very much, Steve. So we will add that to the action log. So thank you very much. So what I'm asking is for colleagues to note the content of this report, but also be cognizant of the need about it being adequately resourced as an expanding and system critical primary care transformation programme. So thank you very much for an excellent report. We're going to move on. Going to move on now to the Torbay Section 75 agreement, and I think Liz, you are going to comment on this, but I'm just wondering who is actually leading on this item. Bill, thank you.
Thank you, Chair. So there's a paper for the board's approval, which is also going to the governing bodies of Torbay and South Devon NHS Foundation Trust and also Torbay Council. And what the paper sets out is the requirement for us as one of the tripartite signatories to the current Section 75 agreement to put in place a new Section 75 agreement between those parties that I've just outlined. In summary, the Section 75 agreement has been in place in some way, shape or form for 10 years, and we are now at the beginning of next month in the 12-month notice period of the current agreement. That agreement will lapse at the end of March 2025, and so we are in the position of having to put a new agreement in place or determine that we don't wish to see an agreement going forward, which would mean that the integrated care organisation that currently exists in Torbay would no longer exist. The impact that would have, having had detailed conversations between the parties on social care in Torbay, would be significant, particularly as we've talked earlier about the current position with no criteria to reside. Colleagues will be aware that no criteria to reside in Torbay is amongst the lowest in the country, and that is clearly one of the benefits of the joint working that's currently in place. That said, the discussions that have taken place and the dialogue and negotiation that's taken place between the parties has revealed a requirement to have a much more business footing going forward. I think it's fair to say that the current arrangement could be described as a gentleman's agreement and one that needs to be much more robust going forward. And as a consequence of that, a lot of work has gone into developing the Memorandum of Understanding between the parties, which will then form the basis for the detailed Section 75 agreement that is negotiated and agreed during the course of the next financial year. Board members will see that there are significant financial challenges currently within social care in Torbay, and these have been highlighted as part of the financial situation that the NHS Devon system finds itself in the current year. At the end of this year, that's around £12.9 million, but as the paper demonstrates, that will increase to between 30 and 36 million pounds, depending on whether one takes a view in terms of the non-recurring or recurring position, but it's a significant financial problem that has to be dealt with. The three parties have been working and have been assisted by Channel 3 Consulting, who have done some detailed work. They've been engaged by Torbay Council, and they have helped put in place a series of discussions and workshops that have allowed the parties to work through what the art of the possible is in terms of the financial situation going forward. And as the paper sets out, in order to get into a financially robust position will require some additional grip and control within the organisation than is currently evident. Also significant transformational requirements to take place. But in addition to that, the Council have agreed to ensure that there will be additional funds made available through council tax increases over the period of the agreement. There is significant work that still has to take place, and that work will take place during the course of 24-25. The reason for bringing the paper here is that we're at a critical juncture, really, in terms of making a decision to continue with the existing arrangement, to undertake the negotiations and dialogue that's required in order to have a Section 75 agreement in place from the 1st of April 2025, and to allow the various parties to undertake that work and continue those negotiations, which so far have been fruitful, to ensure that a financially robust agreement is put in place and that this will no longer be a drain on the financial position within Torbay and South Devon Foundation Trust, and consequently on the financial position of NHS Devon, particularly bearing in mind the discussion that we've had in terms of our National Oversight Framework Segment 4 requirements. At that point, I'm happy to answer any questions, and I'm sure that Liz will want to provide further flavour from the ICO perspective.
Thank you very much, Bill, and also for pointing out the very significant benefits that have accrued from this model and the pioneering nature of it. It was really groundbreaking. But I'm keen to bring Liz in.
Thank you, Sarah, and thank you, Bill. So I think you've provided a very great, very positive overview of where we are. Just a couple of points I'd want to pull out. One was that the Integrated Care Organisation, established in 2015, developed a very specific integrated model that a codependency across those different elements of service is important to delivery of the model going forward. And a decision to step away from this would mean unpicking that and returning all the elements of social care back to the local authority. But we know in order for us to be able to continue to get some of those benefits, a number of pieces of work need to be done. And Bill's talked about service transformation as being key to that. And we have engaged with external partners who have done work with us collectively to identify a series of service transformation opportunities that we feel are credible and are set out in the plan here. We've also recognised the importance of ensuring effective grip and control, not just in this environment, but across the breadth of our business. But in doing the work, we also commissioned an external piece of work from external local authority expert that helps us understand how we could better strengthen the governance arrangements across the local authority and the trust in support of this plan. And the details of that are set out here as well. So we're bringing it, certainly I'm taking this to my board tomorrow. Our aspiration is to continue with the arrangement because we believe it delivers the best outcome for our local community, but have to accept with that recommendation comes a commitment to transform and ensure effective grip and control around expenditure for social care going forward.
Thank you very much.
Yes, thank you. And I'll say at the start that I support the recommendation on the basis of what's in the paper, and also Bill's and Liz's interventions there. But what I will say is it does set out a financially unsustainable situation, doesn't it? And then there are a number of work streams and a number of further income streams that are set out in there. But when I add it all up, it doesn't get to financial balance. And I accept it's not comprehensive, but even if I take the top of the range of what might be possible. So for me, the assurance that we probably haven't got today is that we've got a way of making this financially sustainable. But I think we probably just need to understand in a bit more detail when we'll have that more fixed position on how we're going to manage the finances of this, and then how we're going to monitor the delivery of that, and where that is going to be monitored, and the role of the ICB in that. So perhaps either Bill or Liz, you could just expand on that aspect of it so that we can get a bit more assurance than we've got at the moment.
Thank you. As I set out, this is effectively the beginning of the journey. We've been undertaking work between the parties probably for about 4 or 5 months now, and it was really essential that we came to a conclusion about whether an agreement would continue or not. So this is very much work in progress, Kevin, and there will be additional opportunities that are highlighted. So what this sets out is the position as we currently understand it in terms of what's been identified on income, and I think that the income position is one that's fairly fixed. Clearly discussions with the council, as is the case with every local authority, are very much framed in the context of section 114 and the impact that that will have. Torbay is not a huge council, and so its ability to put additional funds in is quite constrained. So I think we've done a good job to get them to commit to additional council tax contributions going in. In terms of grip and control, as Liz said, there is further work to be done there, and we know that in discussion with Torbay and South Devon, there's quite a lot of work that the ICB is supporting the Trust with in terms of grip and control, in terms of getting grip around, for example, workforce numbers and various other aspects. And I would expect that to also feature in the social care component as it has done in the healthcare component. And on transformation, this is an initial view of what we see as the transformational potential. So that board members are aware, the council actually, in the first instance, commissioned another consultancy to do some work. That indicated the size and scale of the transformational opportunities, and they've then, through open tender, committed to using a different consultancy, and their initial view is these are the transformational opportunities. My expectation is working together that will increase, and we're very, very clear that we have to close the gap. So one of the key things that has to happen during the course of this year, prior to the final agreement being signed and everything going forward in that respect, is to make sure that the gap has been closed. And there'll be a combination of those 3 aspects in terms of doing that.
Thank you, Bill. I'm going to bring Graham Clark in and then Liz.
Thank you very much. So the paper hopefully sets out the benefits along with the challenges in taking this forward. And as already noted, this is an arrangement that was put in place some years ago, and certainly before I joined this board was regarded as one of the poster childs of success of bringing closer together health and social care, which I think is very much needed. Given the creation of the ICB, can I just check that this agreement is consistent with how we want to take forward in general in Devon, how we align to LCPs, how we're going to deal with that closer alignment elsewhere? I suspect I know the answer is this is absolutely consistent with that, but I just wanted to check that this is now consistent with the creation of the ICB and how it wants to improve service connectivity.
So, Philip, I may want to add to that, but certainly in governance terms, the ICB, the situation with the CCG was effectively novated to the ICB, and we are part of that tripartite agreement. So any agreement going forward, we would be a signatory to that, which is the reason it's come to this board. In terms of consistency with what we're doing at locality level, I think it's arguably the case that that's more well developed in Torbay, given the social care aspects as well as healthcare, compared to the other localities. So I think it's entirely consistent with that aim and objective.
Thank you.
Good, thank you. Good news.
Thank you. First of all, I just want to concur with Bill's a response to how we're going to progress this, but this is at the early stages. But I wanted specifically to pick up on that and how are we going to oversee delivery. As a consequence of the review that was conducted into overarching governance, it's been agreed that we're going to establish an executive committee across the council and provider sector with senior, chief exec level engagement, and that will be charged with ensuring delivery against this plan.
Thank you, Liz. I'm going to come to Alison Williams and then finally Frank O'Kelly.
Thanks, Chair. Just really bringing this back to the context of NOF4 for a moment. And I think we shouldn't forget that one of the collateral benefits of the model is when you look at the no criteria to reside and the impact on UEC, it is markedly different in Torbay. So there is a value to the model which is more than the financial impact of it. And so we mustn't just lose sight of that specifically. I suppose if you're just looking at it in terms of the bold financial impact, the model does put the risk of social care increase into the health system as opposed to into local government. And so just a question, Bill, I guess, in terms of the onward negotiations and the risk share around that, notwithstanding all of the things that have already been said, that there's skin in the game for social care, for the local authority as well as health in sharing the risk of that demand growth and that financial impact going forward, so that it doesn't feel solely like a risk that sits with health. And then I suppose finally that with the additional work going forward, and it plays back to Graham's point, that balance between the model impacting on overall performance and the cost and the future direction of travel, probably not for this year, but actually an evaluation that would understand the impact of that potentially on UEC performance more widely across Devon for the future is probably something to put into the forward plan.
Thank you. Frank O'Kelly.
Thank you, Chair. I suppose my only question would be, does this have any disadvantages in terms of potential developments across the ICS? The provider collaborative is very much in its infancy. If things were to change in terms of the acute provider collaborative, would this restrict it, or would it be easy to merge, for instance? I'm not saying that's going to happen, but it's quite early days in terms of the provider collaborative.
Thank you for that question. Liz Davenport, did you want to respond?
As you say, Frank, we're in the early stages of understanding the work of the provider collaborative and the model of acute delivery going forward. But I think we have to see this in the context of place-based delivery. And if we continue to optimise that out-of-hospital model and take the benefits that can, and maybe we haven't yet fully accrued, that we can strengthen, I think, some of the opportunities that come out of the acute provider collaborative work programme.
Thank you. And Bill.
Thank you, Chair. Just to try to address Alison's points, the default position is that the current deficit falls to health. That is the nature of the Section 75 agreement. So if we do nothing else, the two options we have are that we continue with the current agreement and we see the deficit increase potentially up to 30 million or beyond that, or we terminate the agreement with all the impact that would have in terms of the impact on social care, no criteria to reside, and so on and so forth. So the thing is, how do we get to a position where we limit the exposure that health currently has? And that's the purpose of the discussion and the dialogue and the negotiations that's taking place to go from a 12 million deficit as currently to make sure that doesn't get to a 30 million plus deficit, and to work through collaboratively with the other party, because they are commissioning the service. They're very clear about what's available in terms of providing that service, and as healthcare providers we can choose either to provide that service or allow someone else to provide that service, with the impact that would have in terms of the elements I've outlined. Key within that will be to get the specification right, and there is a view, whether it's correct or not, there is a view that what is provided in some cases is a gold standard service. So part of the discussion will be about what can be provided for the available funds and the extent to which that will provide the service that we require. That is something that we're looking at in all aspects of health and social care within the NHS at this time. So I don't think it's any different from that. What will have to be very different are the development of KPIs, because I think it's also fair to say that we have not been as good as we should have been in terms of performance managing the service and being absolutely clear about what is delivered and whether the requirements of the contractual arrangements, which will be the case between ourselves and social care, are optimal and whether we're delivering. So I think that that will help to limit the exposure that we have. To be clear, the ICB has not and is not underwriting the deficit at this time, but de facto, given where we are in NOF4, deficit in an organisation ends up being a system deficit anyway. So it's largely something in terms of appearance rather than the actual fact.
Thank you. Steve, did you want to have a final last word?
It was only just on a general point. I think all the points well made, particularly around the way in which we need to work together on this. I remember being in the Devon Cornwall system when this was set up back in the day, and it was absolutely seen as the way forward. I think nothing's changed in that regard. Actually, that integration in its most general sense between health and social care, not least because of the demographic challenge we face, both for the people we're looking after, but the amount of workforce we're going to have between us to be able to look after them, is really key to all this. So I think I was reflecting on the question about whether it sort of fits the direction of travel. I think it absolutely does. Whether the same solutions are needed everywhere, I think it depends very much on local circumstance. Whereas the underpinning principle of needing to integrate better, I think, remains. So we'll need to look at some of the benefits of this and how we can get that to other parts of the system. Clearly, a very low, no criteria to reside position. We can think about the patients involved in that as much as anything. That those are people then who are more often back in the place they need to be, being supported in the way they should be, at probably much lower cost than can be done in the acute sector. So there's a whole range of benefits here. We do need to work through the risks. We also need, as part of that, to maximise the opportunities for this, not just for the Torbay system, but about what we can learn for the wider system in Devon.
Thank you very much. Now, I'm conscious that we're running rather behind time, but I just need to ask the board's approval for NHS Devon entering into this new tripartite Section 75 agreement and enabling the delivery of integrated adult social care in Torbay from April 2025 to March 2030, but in additionally to delegate authority to our new Chief Executive Officer to sign that agreement. So could I ask if there's anybody that has any disagreement with that? No? So thank you very much, Philippa. Now, we are running a bit behind, and I'm just proposing that we just take a brief comfort break now, otherwise everyone's going to get very tired. So shall we just take a comfort break for 10 minutes and then return? So thank you. a big fun because we're not live just yet. We're just waiting for a few. So welcome back to everybody following outside the room for our NHS Devon board. And we're going to come on now to the section on our integrated quality performance and finance report, much of which, of course, will have been covered in an earlier item. But Anthony.
Thank you very much, Chair. Yes, as said, we've covered an awful lot of ground already in various different discussions. Therefore, I'm not going to go through the whole report. There are a couple of things I want to add, though, and just draw people's attention to. So in terms of elective care, we don't talk about cancer perhaps enough, but just to note that we did meet our 28-day faster diagnostic standard, so back onto performance in that particular area. And I think in context of some of our long waits, that's particularly important that we do pay attention to that element. In terms of urgent and emergency care, which I think we have covered at great depth, just for noting and not for further discussion, obviously UHP's continued performance and some of the issues there in terms of ambulance turnaround times is worth noting. They are in receipt of a performance notice from the CQC. We're not intending to go into any detail there as they need the right to be able to respond to that, but I'm sure it will come up at subsequent meetings. In terms of other elements within the report, and I appreciate the conversations around primary care earlier, I think it's really, really timely and would be a good use of our time to have a board seminar, particularly diving into some of those elements. And we have done an awful lot of work preparing information for a meeting that now isn't going to happen, so I think we can supply an awful lot of information in relation to that. But I think one thing in terms of context is to note the increase in demand for primary care, which wasn't specifically mentioned, but currently sitting year to date at 9% increase for primary care. So that just makes our achievements in that area even more important to note. I've asked colleagues to comment both in terms of children and young people, so Nigel is going to comment on that element, and also in terms of quality. Penny Smith is going to comment on that particular area, and then for any time left, Piers will comment on the workforce sections within the report as well, and then I'm happy to take any overall comments or questions.
Thank you very much. I can see Penny is poised to go. So Penny, I'll bring you in first.
Thank you, Chair. So the quality section has been expanded slightly, albeit that I draw board members' attention to the fact that we've got a standalone quality report for the first time. So these are high-level considerations related to this report. So you'll note that serious incidents haven't been reported in relation to ambulance response times, which is quite unusual, bearing in mind the fact that we have exceptional waits within UHP. What is Anthony Helmsley and Darren Alcorn and Jane Chandler from SWAST are working together to identify harms that occur outside of the pathway, and that will be the subject of the of discussion at the UEC board. And that's appropriate at this time because the serious incident framework is changing. But that retrospective position is curious, and hence this additional work. I think the other item of note is the Joint Targeted Area Inspection, so commonly known as the JTI. So this is, and obviously this relates to Torbay. The ICB is the principal authority, and we're working across all agencies, so it's multi-agency response to develop a written statement of action by the 9th of May. That work is progressing to time, and we have worked particularly with Torbay, although there are actions across all of the multi-agency partners to make sure immediate remedial action has been taken, but that written statement of action will need to be considered by board, probably by correspondence. I'll work with Philippa.
Thank you very much, Penny. Could I bring Nigel Aitchison in next? Thank you.
Many thanks, Chair, and thanks, Anthony. So the two sections that you'll see are the ADHD waiting times and our speech and language therapy waiting times. And perhaps for the board, this obviously forms part of our wider children and young people's work, which the board is well aware of, and I think needs to be considered in that context. And we'll bring back more detail on all of these. With reference to the ADHD waiting times piece, which as the board are aware is a national problem linked partly to the massively increased prevalence, we've got a business case for which is being considered through our investment group process that Bill chairs to try and switch off the tap of demand for these assessments by approaching this as a needs-based way forward. And we've been engaging with children and young people to try and do that, which would be providing key workers to support the needs that these predominantly young people have, to avoid the need for the very long waits that you see referenced in the report to get a diagnosis before they can then have their needs met. And we think that this is something that would provide a much better solution for our system, but in particular for those young people predominantly and their families going forward. And it's something that we're keen to progress with, and we think that will address the sort of the upstream piece of this. It does still, however, leave the backlog of assessments that we need to do. And what we're currently doing is working on accurate trajectories, picking up again a point that Bill made a little bit earlier on about the need for us to have a much more rigorous approach to performance management of these kinds of areas. In speech and language therapy, whilst you'll see a stabilising position, it's not a position that we're comfortable with because it still leaves a lot of young people on that waiting list, and we're working with both of our providers to try and again formulate some trajectories to reduce that waiting list, which, although stabilised, is still too high, recognising that for at least one of our providers there are still significant issues in terms of being able to recruit the expert colleagues in speech and language therapy to help us reduce that further.
Thank you, Nigel. And finally, when we come to Piers. Thank you, Piers.
Thank you, Chair, and thank you, Anthony. So just a couple of points to highlight from me from the report. It's fairly clear from the workforce section that the agency spend is higher than we predicted, so that is an area, as you might expect, of focus for us over the next 12 months through our operational planning. And there's a significant SIP saving attached to that. We know there's a lot more to do, although I have to say the providers have been very proactive in this space, and although the spend is above plan, it's still below the limit that NHS England set for operational planning this year. And then the second point was already been raised earlier about industrial action. So we've commented, and we need to keep a close eye on industrial action in relation to the dispute that still goes on with junior doctors in relation to pay that's for the financial year 2023-2024. However, we also need to keep a close eye on whether there will be any other dispute over pay negotiations for the forthcoming financial year. And as yet, we don't know anything about that, but that's something we will keep a close eye on because we've seen the impact that industrial action can have on our workforce numbers and costs. As Judy quite rightly raised at the beginning of the meeting, we absolutely need to have a close eye on all those things.
Thank you very much for three really helpful points to add to this. Sheena.
Thank you very much. Could I ask a couple of questions about the children? I really welcome the shift towards trying to do something a bit more proactive before people have formal diagnoses. Really, really important. And I also recognise that there is a big increase in demand, partly because people are doing their own online assessments or getting other private assessments, and it's not helping. Nevertheless, we still have to do those assessments. We can't not do them, and we've got this appalling waiting list. So are we assured that we're taking advantage of innovations that might help speed up assessments, such as digital platforms with assessment tools, but also sharing records on progress between partners, etc.? You know, are we being as savvy as we can with the tech? And secondly, CAMS. I ask this question at every board meeting, so why change what I'm doing? Do we know if and when we might expect to receive information on waiting times for CAMS?
Nigel, would you like to respond on?
Yes. So going backwards first, I think we shared the data on CAMS that we have. I think we shared that with you, Sheena.
Yeah, you're right, actually.
So, and then going back to the digital piece, so we do have issues around the data with children and young people, in the sense that where people are on certainly acute hospital lists and so on, we find it very difficult to pick out the CAMS referrals from some of the waiting lists, and that those data issues are not just peculiar to Devon, and they are areas that we are working on with partners and colleagues nationally and regionally. In terms of the digital piece, I mean, we are keen to explore, because of the scale of this problem, some digital approaches, and I know you very kindly shared one of those which the team are looking at, but absolutely, along with the comments on primary care, that is something that we, in our new operating model, need to find a way to link the work of the digital work stream our chief clinical information officer and others are doing in these areas. So, but yes, we're really interested in that because of the scale of the problem.
Thank you. Could I come to Steve if you have any comments to add? No.
Took me by surprise. No, I was just reading the actions around autism and ADHD. So no, I think we've probably run through most of the issues already. There's clearly, as Nigel said, work to do generally around children and young people services, but particularly in mental health terms, and innovation is going to be really key to that. So.
Thank you. So looking forward to hearing further updates, and the board is going to note the current performance position against the KPIs measured through the IQPR. We're going to come next to the board assurance framework, and Philippa Harding, our company secretary, is going to lead off on this. So thank you, Philippa.
Thank you, Chair. The report provides the usual update in terms of the strategic risks faced by the organisation. So I won't go into the detail of that, but I did want to bring to the attention to the board the proposed new approach to the BAF in the new financial year. And this is to move us away from a focus on specific deliverables to a much more strategic, thematic approach, which is aligned to our NHS oversight framework. I'm pleased to say that the proposed approach has been reviewed at our Audit and Risk Committee, and the Audit and Risk Committee has agreed to recommend the proposed approach to the board, which members will see from the Audit Committee Chair. And then aligned to that, the report also includes information about a proposed risk appetite statement to be adopted alongside the thematic approach to the BAF. I think it's important to recognise that this is an interim approach to a BAF as we work through our delivery of an annual plan and further work around the integrated care strategy and so on that we've already talked about at this meeting. And as we develop that work, we'll obviously be able to develop much more strategic thinking around our risk in those areas as well. I think that's probably sufficient introduction from me, and I'll leave it to people to come in.
Thank you. Could I perhaps come to Graham Clark, then, as Chair of the Audit Committee? Graham.
No, actually, I don't think got much to add. We did indeed look at it. This has, of course, been an ongoing thing of development, and I think I endorse what Philip has said.
Thank you, and I know Steve would like to come in. So, Steve.
Yeah, just to reflect, I know a huge amount of work has gone into this, and I think the proposal about how we move it forward is going to help really focus the board. I think the board assurance framework, once fully developed alongside a clear strategic intent, probably becomes the most important way in which the board can guide its agendas, what it talks about, and what it attends to. In West Wales, I got to the point with my own board where the board assurance framework was the most exciting thing that we talked about. And I say that because probably we would have the opposite opinion about board assurance frameworks generally, but they can, if properly set out, be really clear about how we know whether we're being successful in strategic terms, whilst we're also focusing on the tactical and operational day-to-day things. And for a board, particularly an ICB such as this, we need to be able to keep our heads up. So I think I'm at the beginning of a journey with Philippa and others. I've started to sketch out some of my thoughts around that, and other than the odd look of consternation, very much supportive of how we might move forward with that. But it's going to be quite a long developmental pathway, and to go back to where we started, therefore the move this year to something which is much more focused around the business of the board now, I think, is a useful first step in that regard.
Well, Thank you very much, Steve. So if there are no other comments, what we're looking for here is to approve the latest iteration of the BAF risks to achieving the strategic objectives for NHS Devon, and to approve the proposed approach for the BAF for the 24-25 financial year, which is aligning it to the 6 themes within the NHS Oversight Framework, and to approve the proposed risk appetite statement for 24-25. So does anyone have any comments that they wouldn't agree with that? No. Thank you very much. So.
Yeah, thank you, Chair. I won't go through all of the paper in detail because I took members, obviously, through the results in great detail at our last development session. But if I can just highlight some things, because I think they relate to what Steve mentioned right at the outset, Chair. So structural change in the NHS is not new for any of us if you've been in the service for a while. Clearly, people go through that. But actually we shouldn't underestimate how unsettling that is for our staff. And I guess we've been looking at our structure for the last 15 months, and that's because of a combination of 2 factors. The first is we were already overspending on our running costs as an ICB. To the tune of 6 million, and clearly we needed to take some actions to address that, and that took quite a number of months, probably 6, 7, 8 months to look at. And then we had the additional challenge from NHS England to review our running costs and cut those by 30% over the next 2 years. And actually I don't think many of us have experienced making cuts of 1/3 of our workforce in that time. And I mention that because that's the backdrop, of course, to when our staff filled out their staff survey, which is an annual thing that the NHS does, and is really useful because it gives you some comparisons with other organisations. On top of that, of course, we have a lot of scrutiny, quite rightly, around our NOF4 status, and indeed we also moved into these offices. We had 5 offices previously and decided to move to 1 to save us about £500,000 a year in our running costs. But of course that is also disruptive and unsettling for our staff. So all of those things I think are not an excuse, but they are important context I think for the staff survey, because our staff filled it in last November where they will have been going through all of those things. And also equally it's brilliant to have Steve here as new chief exec, but of course our staff have also experienced 3 leadership changes in as many years, and again that's a bit unsettling for people. It's really, I guess, painful for me because actually we were making some really good improvements to how staff felt about working for NHS Devon. For the 4 previous years until this one, we'd made really good progress on making the environment and the culture good for our staff. And indeed, last year we were the 5th best as a workplace of any equivalent organisation. But of course that's actually been clearly eroded this year given the context. So I just wanted to highlight that because I think it is important we recognise that it's quite an unsettling period for our staff still. Steve's committed that we will go out to consult with our staff on the 21st of May, which is a date that we have firmly in our minds. And I think once we've gone through that process, it will then settle our staff. We'll need to do a little bit of work around culture and OD to rebuild and make sure everything's fine, and indeed have a vision for our new organisation as we go forward, because we clearly need to look at what we do in light of having 1/3 less people who work for the organisation. The paper does outline some of the areas that staff feel we need to look at, and there's some irony, I guess, in some of that, because a lot of our staff feel that we don't have enough resources currently to do the job. That was one of the big bits of feedback we got, and also the sheer challenge that they face in coming into work. What we've outlined in the paper are some short-term actions which we're already progressing. We've had directorate sessions to look at the results in great detail. We are obviously making progress on the structure, which I think is key, and then we have some more longer-term actions to really look at how we work in future, so that we get back to this being a really great place for people to work, because that's always been the case. I'm happy to take any questions from members.
Thank you, and I'd just like to start by saying thank you again to all of our staff and recognise the extraordinary pressure that colleagues are under. Can I just come back as well and say that I welcome the discussions that have been happening within individual directorates, because there is variation in that, and it was a great privilege to sit in on one of those discussions to hear the work that's going on individually in teams. So thank you. I know that Kevin Alford would like to come in.
Yes, thank you, and thank you, Andrew, for that context to the staff survey, which I think is really really important to have as we discuss this. This is a point in time, as you've mentioned, and I just wanted to ask Piers probably where we are with. We were talking about having a kind of flash staff survey, kind of once a month or something, which was very 5 questions or something that we were going to implement. And I just wondered where we were with that, because given where we stand at the moment, it might be quite useful to have those more regular updates rather than the annual survey.
Yeah, it's a good question. It's a combination answer, I expect, between Andrew and I, because it'll be probably delivered by the comms team. But I forget the title of the sort of flash survey that you talk about. But there's a recognised process that other parts of the NHS have implemented, and NHS England certainly have, and encouraged ICBs to follow suit. So we've been working on that to find a process that fits for our organisation. But I don't honestly know where we are with that, Andrew. You probably do.
Yeah, so we're close, Kevin, to doing that. We do work. Piers and I meet with what we call our staff partnership forum, which is a group of fantastic individuals who represent the views of our staff, and we've been working with them about the timing of when we best do that. They sort of feel a bit surveyed out at the moment and structured out. So what we were going to do is pick a best time to perhaps do that. I think that will certainly start probably in the next 2 or 3 months, where we will do a regular sort of flash survey using things like SurveyMonkey, which others use, so that we can get a feel for how staff feel. The other bit we do is the partnership forum is a useful barometer also for testing the views of our staff. And as I say, Piers and I meet with them fortnightly. Steve joined the last one, was given a little grilling, but actually I think Steve got a good feel for where people were based on what they said, and I guess it highlights the things I mentioned in the context, Kevin.
Yeah, that's helpful. I mean, I would encourage us to move to that system, and I wanted to kind of add another action to to the actions that are in here, because I think there is probably a role for the Remuneration Committee to just have an ongoing oversight on the impact of these actions over the next few months, and there's maybe a bit of drilling down that committee could do. I mean, we highlight in here a positive score. Under our positive scores, we say, compared to the ICB average, 88% of our staff say that adjustments have been made to enable me to work around my disability, which might be a positive response compared to ICB average of 78%, but it depends who the 12% are, doesn't it? So it's that kind of drilling down that I think the Remuneration Committee might want to do. So perhaps as an action for me and Piers to just touch base on this and think about how the RemCom could most usefully help turn some of these scores round.
Well, thank you very much for taking that on, and also for your work as Freedom to Speak Up Guardian and our other colleagues in that field. Frank would like to come in. Frank O'Kelly.
Thank you, Chair. For me, this is probably the most important report in the whole pack today. I was really heartened that Steve focused on it right at the beginning. We have had a drop of 27% in the last year, and that is the first year of us as a board having set the environment for which our staff are working. So we absolutely have to take responsibility for this, and we desperately need to turn it around quite quickly. So thank you, Steve, for focusing on it.
Thank you. Tandy Hara.
Yeah. I just want to know, is there a timeline for your organisation development piece? Because for me, we haven't got time at all. Some of this, the organisation development of the culture piece almost needs to happen in tandem with what we're doing, understanding that there isn't time for that, but I don't think we've got time to do them in sequence in that kind of sense. I just wanted to get a feel of what timescale you've got in mind for that.
So good point, Tandy. I think certainly it's one of Steve's big areas of focus, and in fact in the structure proposals that we've got, we are beefing up the organisational development side because the resource on it at the moment, Tandy, is quite slim. But actually, Katie, who leads on our organisational development work, has been part and parcel of the directorate sessions that we've held. So she's attended all of them bar one, and then one of the HR team attended the other. And what she's found are some themes that we may need to look at in terms of how we rebuild the organisation. So I'm proposing to take some of those themes to one of the next exec committees that we've got, because I think that's the start, Tandy, that we need to make. We've got to get on with this, haven't we? I've always been proud that Devon has been quite a nice place to work for our staff. It doesn't feel like that at the moment because of the pressures and the structural changes which are unsettling for everybody, and we need to get that back into a really good place.
Thank you. And Alison Williams.
I hadn't noticed it before I was sitting here, but if you look at those ICBs that have had the biggest drop, they're actually the ones that are in NOF4. So it's possibly not as much about the organisational change, because all of the ICBs are going through organisational change. It is possibly the combination of organisational change and the associated pressures of being in NOF4. And I just wonder, Anthony, whether or not that's something perhaps we need to take away and have some conversations about, because it is that degree of scrutiny and oversight is bound to have an impact, and we may need to think about that, because there are going to be other organisations going into NOF4 over the next year or two, and if there's some learning here that will help Devon, but also perhaps help the wider NHS, then we need to capitalise on that.
Thank you. I'm going to bring Judy Hargaden in on that point.
Just one small point. As people know, I've been co-chairing with Andrew the organisational change group, and we did a report to the REMCOM last week. And one of the things that just occurs to me when you want to wait a while before doing the survey is it's very easy to think we need to do NOF4, we need to do organisation change, and then we will start these various initiatives. And I would urge the executive, and I said this last week, to think about small things you can start now. It doesn't have to be a big major OD scheme. It doesn't have to be just little things that begin to give people confidence that we are recognising these issues and moving forward. But it's a classic that organisations with two really big, difficult problems going on at the same time will say, well, let's get these sorted out and then. But I think it's and now, maybe.
Thank you. And on that point, I'm going to bring Stephen for the last one.
Yeah, thank you. And I kind of agree in many ways. This is one of the key reports for us to look at, because our ability to be able to do the things we're being asked to do clearly relies on having an organisation which feels strong and supported in all of this. And a couple of things to reflect. I wasn't aware of the flash survey thing. I think it's a great idea. I will talk to the team about how we might be able to do that. I think I'm with you, Judy, on this, in that I think the sooner we start it, notwithstanding our bandwidth issues, so I do need to not push people over the edge here within the team, it gives a signal as much as anything to staff that we are keen to ensure that we are keeping engaged with them through a difficult time. So even if people don't feel able to fill it out, even if we do it very easily, it gives the right message that actually we want to be connected to people, we want to hear their views. In West Wales, we did a flash survey of 1,000 random staff every month. We had about 12,000 staff in the organisation, and we wanted to get everybody at least once a year. And to link back to the previous discussion, it fed our board assurance framework so that we knew as an organisation where we were in terms of our OD, our skills development, how people felt, all of those things. Got a bit of a way to go with that, but I'd be keen that we make that move towards that. Not least because, to pick up Alison's point around NOF4, I can say probably slightly candidly, knowing this is a public meeting, but the debate we had with Welsh Government when we first went into targeted intervention was we needed to spend as much time on organisational development and health and well-being of our staff as we did on the targets that they quite understandably wanted us to meet. I think we've got to attend to that, not least because, as we've heard on the rest of the agenda today, the only way we're going to be able to solve some of these enormous challenges, both in the short term around the NOF4 exit, but also in the medium and long term around our population, supporting a growing elderly population and a falling workforce, is we're going to need people to be creative. We're going to need people at the top of their game, able to use and develop their skills, because there aren't going to be enough of them. So for me, it sits at the bottom of the pyramid of everything that we're trying to do. And I think there's been a lot of progress within the organisation, and I think I take a lot of confidence from what Andrew said about this was seen as a good, strong organisation before the things that happened. I think we can get back to that quite quickly, but then we need to move on with it, because we're only as good as our people. So we'll take all that away as a team and make sure that we've got a coherent plan around all of that.
Thank you very much. So the board's asked to note the staff survey results, but also to support the actions set out in the report. So colleagues can tap with that. Thank you very much to everybody. We're going to come now to the section of our board meeting on working with partners. We have a report from Kate Shields as the Chief Exec of the Cornwall and Isles of Scilly ICB. Kate unfortunately has had to leave for another meeting, so I'm just going to ask colleagues to note that and take it as read. And then we're going to come to the One Devon Integrated Care Partnership update. And James, I don't know whether you have any comments you would like to add to your report.
I'm conscious of time, so I'll take it as read. But as you can see, we're concentrating on children and young people, because I think this is as a wider partnership organisation, it's really important. And I just recommend that you all actually read the presentation that we received, because I think it's very instructive. It clearly sets out sort of, I don't like to talk about legal responsibilities, but we all have legal responsibilities for children and young people, as well as local government and police and everybody else. And that, I think, is a good basis to work from. Thank you.
Thank you very much, James. Right. Penny Smith.
And also recognising that we're working on the board seminar session around children and young people, which will build on that slide deck. So thank you.
Thank you very much. So next we're coming on to our committee chairs reports, and first of those leading out is going to be Kevin Orford from the Finance and Performance Committee of the 27th of February and the 14th of March.
Thank you, Chair. Just given the time, I'll take the reports as read, but I did just want to highlight to the board that we're getting a high level of assurance around the process that's being followed for the operational plan, the operating plan for 24-25, and you'll see in the report that we're asking that when we have the sign-off discussion at the board in May, that we have a risk and assurance focused discussion around that, so that we're fully focused on the risks and the mitigations and the overview and scrutiny that we need to take on the delivery of the plan next year. That's all I wanted to flag up. Thank you.
So I beg your pardon. So we're asked to note the report. Thank you very much, Kevin. I'm also conscious that we might shortly become incorate, and I'm keen that we hear from those where we're asked to endorse or approve. So the Quality and Patient Experience Committee of the 21st of February and the 14th of March, it's Tandy Hara.
Not too much to add to that. I think the report for the 21st, I made a report on that one at the last one, so I won't spend too much time on that. But the meeting on the 26th, we did cover some of the reports that have been made about children and young people and performance. We did talk about the worsening cumulative performance and quality aspects. We talked about quality and maternity, as well as the complexity of maternity inspections. And there's one issue that we do need to bring to the attention of the board, which is that the need to align the CQC actions arising from the inspections, as well as the NHS National Maternity Support Programme, be sort of thinking there being that actually we need to have those two things aligned to make sure that we're not implementing them in an unhelpful way. So that's just one thing to highlight to you as a priority. Thank you.
Thank you very much. And I can see we're also being asked to endorse the Live Well South West's adoption of the Patient Safety Incident Response Framework. So we're content with that. Thank you very much, Tandy. I'm going to go next actually to audit and risk and come back to Judy, because we're being asked to approve the standards of the business conduct policy, the conflicts of interest policy, the risk management policy, the receipt, acceptance and management of petitions policy, and the policy for the management of the development of procedural documents. So I don't know whether there's anything that you would like to speak to on this, Graham.
Yes, sorry, I am conscious of time, but I do need just a few minutes airtime, if I may, please, Sarah. So let me just rattle through them, though. So yes, there are two meetings covered with the minutes, but to explain why there were two, we're heading towards year end. So a meeting was held on the 19th of February with the intention of trying to clear the decks a bit with the internal audit work. Actually, they hadn't come through, and they still haven't come through. There was rather a back-ended workload, and they are somewhat behind as well. So we didn't get as many internal audit reports as we had anticipated on the 19th of February. Of those we did, there were a couple of things we said that we would raise to the board. There was an internal audit report done which was labelled IT governance and levelling up. We think that's a slightly misleading title in the sense it's not looking at levelling up in general. It's much more specific around the degree to which the IT governance takes account of the need to incorporate that. But they brought in an external person to help with that, and they did make some observations around whether, in fact, our IT strategy in the context of NOF4 and SIPs was still appropriate. That wasn't strictly the heartland of those terms of reference, but nevertheless was an interesting observation, and I think that's been left with the executive to take forward. But there was certainly a concern as to whether the strategy was still wholly doable and appropriate. The other thing we said we would raise to the board was there was a section on the FTSE report, and we noted that we appear to be taking responsibility as the FTSE authority for primary care, and that's quite a big deal. There was a concern as to whether we were adequately set up to really address that. So again, we said we would note that to the board, but the committee in its own right, of course, actions follow up on that. We did approve the external audit plan, and of course that's ongoing. We have yet to see KPMG, or hadn't at that point, doing the field work, but that will be starting, and we will be holding private meetings with them in due course. The meeting on the March meeting was our first sight of the annual report and accounts, but this was the narrative, the report bit of it. So it was great to see an early version, because it was early. I think we all recognise that there's still some work to be done, but the first draft of that is on the 23rd of April, so quite soon. There is another Audit and Risk Committee on the 22nd, but that is really just before the first draft is submitted. but we have at least seen some narrative around that, and it gave us the opportunity for some first comments. Then there were a number of policies that I'll come back to because they need approval. Can I just make another observation on a different topic, which is the Audit Chairs Committee? We had a meeting, albeit not particularly well attended, last week, but with the support of governance, I think we are now making some progress in using the various chairs who come together on a periodic basis, a quarterly basis, to become, as it were, the owner of the system audit work. And there are two being proposed topics to be picked, but it would be great, I think, to see some system-wide audit work being undertaken, which will not usurp or replace those that are done by individual organisations. On that subject, we ourselves will be looking towards what the audit opinion will be. As being told to us, it's still likely to come out as limited. However, as I think I previously reported, the direction of travel is very positive. It's all rather dropping into 4 levels, as it were, a level of assurance. But we're being told that the opinion is heading much more towards the top end of being limited. But there are still 7 internal audit reports and 4 value-added reports outstanding for this financial year about to close, and seeing where those land will finalise what that opinion will be. And then finally, and for approval for this board, we have seen various policies at various stages. These are not new, but there is a little bit of reorganisation. There used to be 2 policies, one about standard business conduct, and the other about working with industry and sponsors. And that also played to some degree with the conflicts of interest. And in the annexes that are being provided today, you will actually see 2 policies, which I think have tried to separate those out into 2. One is the conflicts of interest, and the second is the standards of business conduct. So hopefully those make them clearer as to what those policies are. We've already talked a bit about the BAF, but you see here the risk policy. There is a concept added to here around risk appetite, which we support. It is part of the evolution, I guess, of the maturity of our thinking about what risk management, be it at a BAF level or corporate strategy level, means. And I think the key point perhaps to be taken on board is that risk tolerance is not an end to itself, and we are encouraging more thinking about what the implications are about what does it mean to be open to risk, for example, versus very intolerant to risk. It clearly has a relationship to our mitigating actions and our desire to actually address those risks, which probably, but not necessarily, will incur resources. So we are supportive of the addition of risk the tolerance in the policy document. We think there's probably some way to think through what that really means. The last and final thing I just say, and Steve did say it actually earlier, in terms of BAF and risk management, we are encouraging, of course, that this does become more central to the organisation and the committees in due course. So at that point I'll stop, but Sarah, the key things are actually approval of those these policies that the committee has already looked at. So can I ask for approval for those?
Thank you, and they're clearly laid out. Does anyone have any concerns, or we're happy to approve? So thank you very much.
Okay, thank you.
Right, now we're going to come to the Primary Care Transition Committee report. Thank you.
Nothing to add. There has been another committee since that I thought the chair's report was ready for just
fine, but we'll just get to it.
Thank you very much. And then we're going to come on to the finance report. Now, because we've already had a discussion of this as relates to NOF or exit, just wondering, Bill, if there's anything you want to add to your very comprehensive report?
The only thing I'd say is, as I said before, and just to remind board members that the outturn this year, as agreed with NHS England, will be achieved. Discussion with all providers across the system, and also looking at the NHS Devon financial position for the year that's just about to end. We remain very confident that we will deliver the revised position as agreed with NHS England.
Thank you very much. Does anyone have any burning questions for Bill? Otherwise, we will move on. And we're going to also take the, thank you very much, Bill, going to take the quality report also as read and note that unless anyone has any comments about that. And then we come on to the action register. And there's a number of items that we feel have been completed. Does anyone have any concerns about the proposal to close any of these items on the register? So I'm just proposing that we talk about the ones that are still in progress. Anthony, I know you had the action reference 37. Is there anything you'd like to add to that?
Yes, apologies, Chair and Board. We have a slight delay in that one. I was hoping to bring it back last month. It's going to be actually 2 more months in terms of completion of that work. The work is ongoing, but unfortunately absences in the team have impacted it on that.
Thank you. And then the other one is the VCSE Assembly was going to be approached regarding the involvement of the work of the care coordination.
And that has been completed, and the discussions are ongoing as to what the particular role may be in the new model.
Well, that's excellent. And many thanks to Diana Crump and all of our VCSE partners. So finally, we're going to come to just ask colleagues to approve those actions, and then we're going to come to questions from members of the public. Now, we've received a question in advance which is related to an item on the agenda, and that's from Dr. Peter Rudge. Dr. Peter Rudge isn't able to join us for this one, so what I'm proposing to do is to read out his question and the answer, but I would also like to say that I'd be reaching out to Dr. Rudge to offer to meet him to discuss this in more detail. So his question is, I have served the community of Plymouth for 25 years as a GP. I've seen LCGs, PCGs, PCTs, CCGs, and now ICSs. In that context, I would like to ask a simple question of those that commission care from general practice in my area. What do you want us to do once we've exceeded safe working practice? And I think, Dr. Rudge, if you're following, I think this goes to the heart of many of the things that we have been discussing today, that although primary care is largely excellent across Devon, there are areas where it is particularly stressed. So this is the response, and as I say, I will be reaching out to Dr. Rudge to meet with him. However, in general terms, we do understand that practices are experiencing significant pressure, and in extreme cases, enacting a business continuity plan is necessary. However, it is our expectation that practices should be looking at their internal processes and working with their PCN colleagues on an ongoing basis to manage capacity in primary care. And then a number of examples are given, such as implementing strategies from as early as the day as possible to respond to demands before reaching capacity, using practice resources to their optimum, for instance, by reviewing skill mix, including the most effective use of ARRS staff, ensuring the practice and PCN has access to the national care navigation training or locally sourced alternative and disseminated that learning within the practice, implementing cloud-based telephony and using the data to help match practice capacity to the demand, reviewing triage processes to ensure that they are effective and that the patients really need to be seen on the day are prioritised, ensuring that practice and the PCN is fully utilising enhanced access appointment capacity, involving the PPG and discussing with peers about how they are managing the demand, and fully utilising the resource available through the ICB or national programmes aimed at improving access, such as ECARP, the PCN capacity and access funding, transformation funding, resilience programme and GPIP. Where appropriate, signposting to pharmacy first, and where appropriate, signposting back to secondary care as per the interface agreement. So finally, the ICB recognises that all practices are unique and have their own processes and set of circumstances. The primary care team is happy to discuss the above with any practice who is struggling to reach demand. And so that's the end of the response to Dr. Rudge's question. We have one other question from our member of the public who's joined us today, so thank you very much, which we'll be responding to in writing as discussed. So,
Well, thank you.
You're very welcome. Thank you for coming. Can I ask colleagues if there are is there any other business anyone would like to raise? No? So in that case, I'm going to bring this meeting to a close, and thank you very much, colleagues. Thank you.